हेलो।
ओके करो।
हो गया ना?
हाँ म्यूट ही है।
हेलो।
आ रही है अभी।
हेलो सविंदर भाई, हेलो हेलो हेलो। 14 ईयर ओल्ड नॉन टाइप कल्टीवेशन। हो गया ना? हेलो।
आ रही है अभी।
हाँ। हेलो सविंदर भाई, हेलो हेलो हेलो। शुभम भाई, आवाज आ रही है? नॉन टाइप कल्टीवेशन। ये मेरी है। अरे मैं वही तो कह रहा हूँ ना, कहाँ आ रही है मेरी आवाज? कहाँ है शुभम भाई, आवाज आ रही है? हाँ हाँ सर, आवाज आ रही है। ये मेरी है। मेरी आवाज है। अरे मैं
तो
वही तो कह रहा हूँ, कहाँ पे? यार मुझे लगा हैंड टू हैंड आएगी, इस पे ये लेट चल रही है ना वो। मेरी आवाज है। ठीक है, मैं खुद को ही पढ़ाता हूँ मेरी आवाज। यार hand to hand आएगी, इस पे ये लेट चल रही है ना वो। ठीक है, खुद को ही पढ़ाता हूँ मेरी आवाज। लेट चल रही है। ठीक है, खुद को ही पढ़ाता हूँ मेरी आवाज।
I'm making the letter N the Netflix logo, so drop a comment for one key.
हेलो
Hello, hi. Am I audible and visible?
सर, वो अपनी स्क्रीन दोबारा शेयर कर दीजिए।
पहले वाला ही शो हो रहा है।
दोबारा करूँगा।
अच्छा पहले हुआ है,
है?
वो हुई नहीं थी डिस्कनेक्ट।
जी
ठीक
मैंने
है, अभी डायरेक्ट लाइव चल रहा है तो मैं उसको पब्लिक कर रहा हूँ।
जी
देखना, मैंने ट्राई किया, आपको एंट्री दी, ओपन हो गया अभी नहीं।
ओके सर, वी आर लाइव नाउ।
I think I'm now busy just waiting to see if I go live. अभी live है?
यस सर।
Okay. Good afternoon, everyone. I'm Dr. Sandeep Sharma here. I think it is not yet live. Can't see on my. I've opened for comment section. YouTube पे तो नहीं आया अभी तक.
सर आ रहा है यूट्यूब पे।
YouTube पे चल रहा है बिकॉज मेरे तो नहीं चल रहा, दोनों सिस्टम में नहीं चल रहा.
मैंने आपको लिंक शेयर किया है WhatsApp।
ओके, ये अलग लिंक है. फाइन. आपका ना दूसरा बाकी लिंक्स भी ऑन है, तो बहुत सारे स्टूडेंट्स ने उसमें ज्वाइन किया हुआ, दे आर पोस्टिंग ऑन दैट. तो बाकी के जो लिंक्स है ना, आप उनको डीएक्टिवेट कर दो, सो एवरीवन विल ज्वाइन हियर. ओके फाइन. चल रहा है ना? ओके. गुड आफ्टरनून एवरीवन. So there were some technical issues, so we could not start on time. But what matters is that now the things have been taken care of, and we can start with the discussion. So I hope all of you are doing good. So I'm Dr. Sandeep Sharma, and many of you know me already, and some of us are connecting for the first time. So the exam is just around the corner, and this is a very brief session that I'm going to take up. If you think that I'm going to take this session and it is going to be a replacement for your existing medicine preparation, that is not true, because there is whatever revision plan that you are following, whatever revision that you are doing, you need to do that. But based upon a few PYQs, I have selected some PYQs from the areas which are very frequently asked. And all of these PYQs, directly or indirectly, have been asked multiple times. These topics have been discussed multiple times in medicine in the past few papers of FMG, and they have a high likelihood of being repeated. So what I will be doing here is, I will be discussing the question. All of them are actual questions asked in various years of FMG exam. Then I will be discussing the answer, and then we will be summarizing the topic also, covering everything which I feel is important related to that particular question, right? So it will be a more of a revision thing through PYQ rather than just being discussing PYQ alone, right? Because all of you have access to PYQs already. You're all already following FMG solutions. Many of you are doing PYQs from your apps. So I don't want to repeat the same. What I want to do is a revision which you can remember and which is going to be a revision tool also. This video will be available on Meduhub YouTube channel for later revision also. So once again, you can have a look at it a few days later with maybe 1.5 or 2x speed and do a quick revision again. And because about almost close to an hour has been taken away, and there are other sessions planned. At my end also, there are sessions planned. So we will try to cover the maximum today. In case we are left with something or a few more things are suggested from your end, I would be more than happy to take it again in another session, maybe tomorrow or a day after, right? So without wasting any time, let us start with the question. So the first question we have discussed is 40-year-old. If you remember, very similar question was asked in January paper of FMG exam. 40-year-old known type 1 diabetes mellitus patient comes to you with complaints of polyuria, fatigue, and weight loss. So he's a adult patient with diabetes, but the symptoms are not controlled. Weight loss is there, polyuria is there, and fatigue is there. His vitals were stable, so unlikely to be a complication like diabetic ketoacidosis, where the vitals can be unstable. And HbA1c was done. What is the cutoff of HbA1c, which indicates a good glycemic control? So what they have done here is they have converted a one-liner into a case scenario. And this is what is being done in the FMG exams of late. So what you are supposed to remember in this is a table given in Harrison. Now the exact table, the entire table becomes a bit big. So what we need to remember is, in case a adult patient where he's not pregnant and there are no specific risk factors, the cutoff value of HbA1c to define a good glycemic control should be less than 7.0. And so your answer to this question is C. So what are we going to revise here? Let us do a quick revision. The heading for that will be treatment goals in diabetes mellitus. So what are the treatment goals you are going to use in diabetes mellitus in the patient, particularly type 1 diabetes we are talking about, but they will be relevant for a type 2 patient as well. So on one side, I would write the index. Then on the other side, I would write the goal in a non-pregnant, low-risk adult. In generally, most of them are considered to be low risk. And second will be the goal in a high-risk patient or a old age patient. When we say old age, the old age will be patient aged more than 60 years, right? So what are we going to remember? First of all, what is the cutoff for HbA1c? Remember, we are not talking about diagnosis here. We are talking about the degree of glycemic control, the treatment goal. Kitna hona chahiye when you are treating the patient. HbA1c value should be less than 7%. 7.0% in non-pregnant low-risk adult, and it should be less than 8% if it is a high-risk or old age patient, right? So HbA1c cutoff should be less than 7% and less than 8%. Suppose यही patient अगर होता 70-year-old, so your answer would have been less than 8%, right? ऐसी option होती, and that would have been the answer in the question. Second, what is the preprandial, that is fasting, preprandial fasting blood glucose level? Preprandial means before breakfast, fasting blood glucose level, it should be between 80 to 130 milligram per deciliter for a low risk adult, and it should be between 90 to 140 milligram per deciliter for a older age patient. Third will be postprandial blood glucose in the patient. So what should be the target postprandial blood glucose? Postprandial meals after the meal has been taken. Generally, we calculate it about 2 hours after taking meal by the patient. So it should be less than 180 milligram per deciliter. I hope you know that for the purpose of diagnosis, 200 is the value that we take, whether we are doing a glucose tolerance test or a 2-hour postprandial test. So it should be, treatment target should be less than 180 milligram per deciliter in the patient. And if it is a high-risk patient, it should be less than 200 milligram per deciliter in a high-risk patient. So it should be less than 200. And finally, what should be the glucose variability? Glucose variability, it should be less than 36% in a low risk adult, and it should be less than 33%. The variation of the glucose, the fluctuation of glucose which is happening, should be less than or equal to 36% and less than 33% in an older age patient. And this is the table you are supposed to remember. And this particular thing is what they had asked for you in the exam. Similar thing can be repeated or from the same table. It's a table given in Harrison. It's a very popular table. This table has been asked in NEET PG, it has been asked in INI-CET, and it has been asked in January paper of FMG exam as well. So please add it to your notes if you have not done it already, and do one revision at least before you sit in the exam, because anything which you read once, you will not be able to remember it unless you revise it again in the exam. So let us go to the next question, which I have again taken from diabetes. If you remember endocrinology, many of you don't read well. So I am trying to cover a few endocrinology topics today in today's session as well. So the next question says, in a newly diagnosed case of hospitalized sick patient with altered sensorium and type 1 diabetes mellitus, insulin therapy was started. Which of the following will increase? सबसे पहले, this is not a physiology question, this is a medicine question. You need to understand कि ये क्या कहना चाहता है. What is the person trying to say? It is a type 1 diabetes mellitus, but in case there is a stable patient, that patient will not be having altered sensorium. What is altered sensorium? CNS involvement. So the patient is having altered sensorium, he is hospitalized, and he is a sick patient. So name the emergency where altered sensorium can be there and patient presents to emergency in diabetes. Yes, you are thinking right. The patient is likely suffering from diabetic ketoacidosis, DKA. Diabetic ketoacidosis is what the patient is suffering from. Any patient of diabetic ketoacidosis, the management revolves around three things: fluid management, insulin therapy, and managing the electrolyte imbalance, right? So in this patient, insulin was given. When you start therapy, which of the following will improve? Obviously, if you start insulin in diabetic ketoacidosis, the acidosis will improve. And so what will improve in the patient? pH in the patient will improve. The answer to this question is A. Remember that which of the following will increase, they are asking. Respiratory rate increase नहीं होगा, respiratory rate settle down हो जाएगा. Most of the patients of diabetic ketoacidosis are having Kussmaul's breathing, also called as acidotic breathing, right? Acidosis की वजह से हो रहा है in these patients. I will do a quick review of the topic of diabetic ketoacidosis, but first understand, you can reach the answer directly or you can rule out other options and reach the correct answer. Look at option number B. ये कह रहा है कि अगर आप इंसुलिन दोगे डायबिटीज मेलाइटस के पेशेंट में, रेस्पिरेटरी रेट विल इंक्रीज. दैट इज रॉन्ग. रेस्पिरेटरी रेट विल सेटल डाउन. सो बी विल नॉट बी द आंसर. When you give insulin, glucose urea will increase. That is wrong. Glucose urea will reduce because giving insulin will stabilize the blood glucose level and glucose will not be filtered into urine. Urine osmolality will increase. That is wrong. Urine osmolality increases because of dehydration happening in the patient, which is a feature of diabetic ketoacidosis. यहाँ पर as patient improves, the urine osmolality tends to normalize, it tends to come down. And so the answer to this question is A, that is pH. Okay, A, that is pH. Pratyusha is saying insulin causes hypoglycemia by glucose urea. No, Pratyusha, do not try to go into physiology. This is a clinical question they are asking about, right? So let us do a quick review and it will be easy for you to understand this question again. This is an actual MCQ asked in FMG exam. मुझे पता है आप लोगों ने सिंपल इसका कई बार आंसर याद कर लिया and explanation में 4 लाइन लिखा होता है and we just try to cram up medicine. Medicine is highly conceptual. Yes, the paper always has many bouncers every year in FMG exam, but still we can always focus on a few concepts and these concepts will come handy. So the topic I'm going to take up is a high yielding topic, that is DKA. What is DKA? DKA stands for diabetic ketoacidosis. I will not go into unnecessary details. I know you have an exam coming up in a few days, so I will just go fast, only focusing on the key things you need to know. Diabetic ketoacidosis, first thing to know, it is a life-threatening complication of diabetes mellitus, right? It is seen more. Does it occur in type 1 diabetes or type 2 diabetes? Remember, it is seen more often in type 1 diabetes mellitus. But can it occur in type 2? It can occur in type 2 diabetes mellitus also, right? And it is more common. It is more common in children or sick adults compared to normal stabilized known patients of diabetes. In fact, many of the children come to medical attention कि उनको diabetes है when they present in emergency. I still remember that I have seen a patient where the child was brought with typical features of diabetic ketoacidosis. We did blood glucose. It was 500 milligram per deciliter. हमने सोचा, we counseled the parents कि बच्चे को लग रहा है sugar का problem है, and the parents were like, this is wrong. Nobody in our family has ever got diabetes. Our child never had diabetes. This is why any child who presents sickly, many times diabetic ketoacidosis is the presenting feature in young adults and children or sick adult patients who come to you with diabetic ketoacidosis. Now, what is the triad of diabetic ketoacidosis? The triad of diabetic, naam mein likha hai, three features are there. First is hyperglycemia is present. What is the cutoff to define hyperglycemia? The blood glucose in the patient should be more than 200 milligram per deciliter. Second feature will be acidosis. What kind of acidosis? Metabolic acidosis is seen, right? I hope you know दो तरह के acidosis होते हैं, metabolic and respiratory. So metabolic acidosis. Metabolic acidosis कैसे define होता है? We define on the basis of venous blood pH. Remember that it is not arterial blood pH. ये NEET PG का question है, इसको याद कर लो. Which type of blood pH is used to define diabetic ketoacidosis में acidosis? It is the venous blood pH which is used to define. What is the cutoff to define venous blood pH? Venous blood pH should be less than 7.3. Venous blood pH less than 7.3. Or if that is not available, serum bicarbonate value less than 15 in case of child and less than 18 in case of adult. Yaad kar lo. This is very important. You may get a question in pediatrics, you may get a question in medicine. It is a high yielding topic, so you need to know the definition and cutoff very precisely, right? Very precisely. So either less than 15 in child or less than 18 in adult. And what is the third component? Ketosis. Ketosis. Now, when you say ketosis, ketosis means increased ketone body formation in the body. Now, ketone body formation can be diagnosed either in the blood, we will call it as ketonemia, or they will be diagnosed in the urine, we call it as ketonuria. So, ketosis can be either ketonemia or ketonuria. Which is more sensitive? Ketonemia is found to be more sensitive. And what is the cutoff? You will remember that serum beta hydroxybutyrate. Serum beta hydroxybutyrate value more than 3 millimoles per liter in blood will be considered to be the third component. So in case a child is presenting to you or adult is presenting to you with blood glucose more than 200, any feature of metabolic acidosis and either ketone bodies found in blood, more sensitive, if not possible, found in urine, you will say the patient is suffering from diabetic ketoacidosis, right? So what are the ketone bodies which are commonly diagnosed? Ketone bodies found in diabetic ketoacidosis. This is biochemistry and medicine overlap. Three types of ketone bodies are found. First is acetone. Second is acetoacetate. And third is beta hydroxybutyrate. Among them, acetone and acetoacetate are excreted in urine, whereas beta hydroxybutyrate is found in blood, not in urine. And if someone asks you which ketone body is more sensitive, beta hydroxybutyrate is more sensitive. This correlates better with the chances of severity, with the chances of morbidity and mortality in diabetic ketoacidosis. Another MCQ one-liner, 2019 MCQ one-liner. I will be covering past MCQs, PYQs as one-liner also, right? So PYQ one-liner, which parameter is used to define severity? So remember, serum bicarbonate is used to define severity. It is used to define severity. Serum bicarbonate is used to define severity of diabetic ketoacidosis. कैसे करते हैं? If it is 15 to 18, adult की बात कर रहे हैं. If it is 15 to 18, that is considered to be mild decay. If it is 10 to 14.9, we call it as moderate decay. And if it is less than 10, we consider it to be severe TKA in the patient. That is considered to be severe diabetic ketoacidosis in the patient, right? And then the patient presents to you. You have diagnosed the patient. You have categorized severity. Now you need to do the management of the patient. तो management कैसे करेंगे? Obviously, any patient comes to you, first do ABC. What is ABC? It is an emergency. So airway, breathing, circulation needs to be done. Confirm the diagnosis. Confirm it is DKA. How you will confirm it is DKA? Check for blood glucose, check for venous blood pH and serum bicarbonate, check for ketone bodies in blood or ketone bodies in urine, right? If all the three fulfilled, it is a biochemical diagnosis. You will confirm it is DKA in the patient. So what is the first step in the management? Now, the first step in the management is a NEET PG question, can be repeated in FMG exam. लगता है कि डायबिटीज का पेशेंट आया, गिव इंसुलिन. You never give insulin therapy first. First of all, the first step in the management is always fluid correction or fluid resuscitation. Fluid resuscitation is always given before giving insulin in the patient. So fluid resuscitation is the first step in the management. And which is the preferred fluid? Normal saline is generally preferred. If not available, you can go for Ringer's lactate as well. So normal saline will be given. You will be giving 2 to 3 liters intravenously over first 1 to 2 hours. And then later you will shift the patient to N/2 saline. And once blood glucose falls below 250 milligram per deciliter, make fluid N/2 in 5% dextrose. This is something जो कि protocol है. This is something which is based upon evidence-based guidelines mentioned in Harrison, and you are supposed to remember it, right? So first 2 to 3 liters IV over first 1 to 2 hours. After 2 to 2 hours, patient is improving, shift to N/2 saline. But in case by this time you would already have started insulin. So once the blood glucose falls below 250, you will need to add some glucose so that hypoglycemia does not happen in the patient. Many patients can actually turn into सीधा यहाँ से crash करके opposite side जा सकते हैं. So make fluid N/2 in 5% dextrose, right? लेकिन initially क्या आप start करते हैं? Normal saline is the first fluid to be started. Second is insulin therapy. Second step in the management is insulin therapy. And insulin therapy is always started after 1 to 2 hours of fluid therapy. So never start insulin initially. पहले fluid देंगे, उसके बाद insulin देंगे. There is no role of bolus insulin. There is no role of bolus insulin in age less than 18 years. However, bolus insulin can be given in case the patient is having an age equal to or more than 18 years of DKA patient. तो ये छोटा सा difference है, you need to remember. Management guidelines are very similar, but this is a small point you need to add to your notes. What is the type of insulin you will be using? Never use any long-acting insulin or a ultra rapidly acting. We will always use regular insulin in the patient. And what is the dose you will be giving? 0.1 unit per kg IV, followed by 0.1 unit per kg per hour. Infusion will be started. 0.1 unit per kg per hour infusion will be started, and do monitoring of blood glucose every 20 to 30 minutes. Every 20 to 30 minutes, right? So do monitoring every 20 to 30 minutes in the patient. And third step, apart from insulin therapy, you will go for electrolyte management. And what is the electrolyte management, which is very important? It is manage hypokalemia. Majority of the patient who present with diabetic ketoacidosis, there is either hypokalemia and hypokalemia tends to worsen when you start giving insulin therapy, right? Remember, याद है आपको, when patient has hyperkalemia, तो management में क्या देते हैं? We give insulin dextrose infusion. और उससे क्या होता है? Potassium moves inside the cell. Here, what is happening? Patient already has hyperglycemia. You give insulin, there will be further inward movement of potassium. And by the time patient presents, already he has low potassium content. So manage hypokalemia in the patient. This is very, very important. If the serum potassium level is less than 5.5, add 10 milliequivalents per, add 10 milliequivalents of KCl to IV fluid. And if serum potassium is less than 3.3, you need to give IV correction, IV potassium correction under ECG monitoring. Yes, Pratyusha is saying absolutely rightly. Initially, hypokalemia can worsen in the patient. The mechanism I have told you, whenever insulin is given in hyperglycemia, there is a shifting of potassium inside the cell, and that can cause worsening of hypokalemia. And so hypokalemia management also needs to be done in the patient. And fourth step in the management will be correct the underlying cause. Now, what is the underlying cause? देखो diabetes तो है, वो तो ठीक नहीं होगा, that will not get corrected, but you need to understand that diabetic ketoacidosis is always triggered by a disease in the patient. Typical history क्या होगी, मैं history बताता हूँ. Known diabetes skips insulin dose, starts taking some Ayurvedic therapy, some jamun therapy, karele ka juice, methi ke seeds, and he says, my naturotherapist has said, I don't need diabetes medicine anymore. And in the next 48 hours, this patient might present in the emergency with diabetic ketoacidosis. So in such a patient, your correction of underlying cause will be counseling and ensuring that compliance to insulin is done, right? There is no harm in taking naturopathy and all these medications, but never stop insulin. If there is no insulin in your body, there are very few known therapies which can actually make you start producing insulin. Second scenario will be a patient of diabetes becomes sick, he gets infection, and infection causes more requirement of insulin which cannot be produced, and that can trigger diabetic ketoacidosis. So correct the underlying cause. I'm writing in bracket, for example, in case patient is having sepsis, you will consider starting IV antibiotics additionally in the patient. So IV antibiotics need to be started in the patient. So this is regarding the general management. Remember that it is a very brief management, exam-oriented management I'm discussing, because I know your exams are around the corner. So fancy stuff I don't want to discuss, which you cannot revise and which is not, very likely of being asked in the exam. But one-liner again, PYQ. Another PYQ related to DK which has been asked. As I told you, I will be taking up one PYQ, discussing the topic and discussing additional PYQs inside that discussion only, right? So another PYQ asked 2 times in FMG exam. What is the most common cause of death in diabetic ketoacidosis? Most common cause of death in diabetic ketoacidosis. What is your answer? What is your answer? I'm waiting for it. It's a question which has been repeated. I'm quite sure you have read about it. What is the most common cause of death in diabetic ketoacidosis? Cerebral edema, absolutely right. Pratyusha is absolutely right. Cerebral edema, and that is the answer. And cerebral edema is the one which can present with altered sensorium. Ab topic ho gaya. Before we go to the next question, listen to me very carefully. Kab suspect karoge patient is having DKA, right? If you get a case scenario in the exam, examiner will say patient is known patient of diabetes, or is having polyuria, polydipsia, altered sensorium, pain abdomen. Many patients of diabetic ketoacidosis present as acute abdomen-like features. And there will be Kussmaul's breathing, also called as acidotic rapid breathing in the patient. So Kussmaul breathing occurs because of metabolic acidosis, which stimulates the respiratory center and produces compensatory respiratory alkalosis, right? So ऐसे patient में आप DK suspect करोगे, the rule is very clear. First, do ABC, stabilize the patient. Confirm it is DK, कैसे करेंगे? This is the triad you are going to follow. After following this triad, look at the severity. Severity is defined based upon serum bicarbonate level, and then start with the definite management. Management में fluids, followed by insulin, followed by hypokalemia management, and this is the therapy. If you get a question like this on the exam, I don't think now you will get it wrong, unless it is a tough question, right? So the topic is done, the MCQ is done. Let us go to the next topic. Third question, 35-year-old lady has a sudden onset of severe headache, which was the worst headache of her life she had. Worst headache of the life. She is non-hypertensive but has nuchal rigidity on examination without any fever. What is nuchal rigidity? Neck stiffness. Nuchal rigidity is other name for neck stiffness. I hope आपको पता है कि fever के साथ neck stiffness हो, so that will be meningitis. But fever के बिना हो, that will be indicative of bleeding, where the bleeding is happening in this arachnoid space, and so the patient is having a thunderclap headache with nuchal rigidity. So the likely diagnosis is BSAH, subarachnoid hemorrhage. Absolutely right, my dear friends, you are answering it very correctly. So remember, in case if MCQ says, before we discuss the topic, if MCQ says fever with neck stiffness or meningeal signs, always think of meningitis. But if the question says no fever, but patient is having trauma or headache, and headache will be very severe. Along with that, patient is having neck stiffness or meningeal signs. In such a patient, the likely diagnosis will be SAH. SAH stands for subarachnoid hemorrhage. I hope there are multiple types of cranial bleeds that you know. Extradural hematoma, subdural hematoma, subarachnoid hemorrhage, and then we have the intracerebral or intraparenchymal hemorrhage. So SAH is one of the favorite topics of FMG examiners. So when will you suspect? Examiner will say any age adult patient with a sudden onset severe headache. Patient will say worst headache of his life or her life, thunderclap headache, peaks in less than 1 minute, and neck stiffness or nuchal rigidity is present. The patient is likely suffering from subarachnoid hemorrhage. When the patient is having subarachnoid hemorrhage, few one-liners. Past FMG MCQ one-liner, what is the most common cause? The most common cause overall is trauma. But if examiner does not mention trauma, or if examiner says most common non-traumatic cause, then the answer will be rupture of saccular, also called as berry aneurysms. Rupture of saccular or berry aneurysms will be the cause in the patient. So rupture of saccular or berry aneurysms will be the likely cause. How do you do grading of this patient? Grading of SAH is done by two scales. There is a Hunt-Hess scale and there is a WFNS scale. WFNS scale. If they say, what is the initial investigation? Initial investigation is always a plain CT scan of the head, also called as NCCT of the head. So NCCT, that is non-contrast CT scan or plain CT scan of the head should be done, right? That is the investigation initially. If you do lumbar puncture, you will find a abnormality known as xanthochromic CSF. Yellow colored CSF will be found. Xanthochromic CSF, because the RBCs which have extravasate, they will undergo lysis and produce pigments. So xanthochromia, remember, it peaks at about 48 hours and fades in 1 to 4 weeks. It fades in 1 to 4 weeks. And what is the radiological feature in the patient? First of all, gold standard investigation. The gold standard investigation will be 4-vessel angiography. 4-vessel angiography. And what is the characteristic radiological sign? The characteristic radiological sign will be blood in sylvian fissures and blood in basal cisterns. Blood in basal cisterns, and that will give a starfish or star-like appearance when there is blood in the basal cistern. You can have a look at the photograph also. So there will be bilaterally blood present in the sylvian fissures, and blood in the basal cistern will be present, which will give a starfish or star-like appearance in the patient. Right? Management is initially conservative, followed by surgical management may sometimes be needed in case there is an ongoing bleeding. And traumatic patient versus non-traumatic, again, the management of the patient will vary. In saccular aneurysms, you need to apply clips. Endovascular clips may need to be applied in case there are more saccular aneurysms found on angiography. So treatment part, they are not going to ask you in exam. FMG में नहीं पूछेंगे treatment, so don't waste your time discussing the treatment of SAH. Always remember, treatment of SAH, SDH, EDH generally नहीं पूछा जाता. आपसे दो चीज पूछा जाता है, या तो डायग्नोसिस बताओ और कैरेक्टरिस्टिक फीचर बताओ. So you will either get a case scenario or you will get a radiological image and you have to look at it and tell the diagnosis. So close to the exam, don't read random things, read focused things. Cerebral bleeding is important for your exam. So clips and coiling are needed in case it is aneurysm. In case it is trauma related and bleeding has already stopped with conventional measure, you may not sometimes need to do anything except for supporting therapy. Right? Let us move further and talk about the next question. All of the following, this is again a topic we have a tendency to ignore sometimes. All of the following are consistent with the diagnosis of metabolic syndrome in an adult, except read carefully and then give me the answer. So ये पूछ रहा है which is not a feature of metabolic syndrome. I hope you know. Yes, Jaya, nimodipine is indicated in these patients. Nimodipine is a good cerebral. It's a calcium channel blocker, which is cerebroselective. Okay, all of the following are consistent with the diagnosis of metabolic syndrome in an adult, except क्या गलत है? Metabolic syndrome causes obesity. It is associated with obesity. It is associated with cardiovascular risk. तो HDL level कम होगा. HDL is the good cholesterol. 40 कट ऑफ लेते हैं हम. तो यहाँ पर HDL cholesterol 50 के ऊपर है. तो 50 के ऊपर, whether it is a male or a female, it will not matter. HDL cholesterol 52 milligram per deciliter is wrong, and that is the answer. Now this is a past question. When this question came 3 years back, some people were of the opinion कि sir male female mention था. Some people said male female नहीं mention था. Whether it is mentioned or not, if you look at the options carefully, D option is absolutely wrong. So it will not matter. So you should just have read about the topic and formed some generalization. So let us do a quick revision of metabolic syndrome. What are the criteria? The criteria followed is known as NTEP ATP3 criteria. अभी ATP4 भी आ गया, but generally examiners अभी भी NTEP ATP3 criteria को follow करते हैं. In India, we are still not using the ATP4 one as well as of now. So सबसे पहले, any patient whose you are evaluating for metabolic syndrome, first do waist circumference. So first feature will be elevated waist circumference. Elevated waist circumference. कितना होना चाहिए? In case it is an adult male, it should be more than 102 centimeter. And in case of adult female, it will be more than 88 centimeter. If it is more than this, then we say one feature of metabolic syndrome is present. Second feature, there will be elevated serum triglycerides in the patient. What is the cutoff for triglyceride elevation? It will be more than 150 milligram per deciliter. It will be more than 150 milligram per deciliter. Third, Gautam Prakash is saying absolutely right. Gautam, what you just said is a past MCQ as well. It is a PYQ also. So I will be writing it. So elevated serum triglyceride. Third, there will be low HDL cholesterol. Low HDL cholesterol. What is low HDL cholesterol? In case of male, it will be less than 40 milligram per deciliter. In case of female, it is less than 50 milligram per deciliter. अब इस क्वेश्चन के अंदर चाहे मेल होता या फीमेल होता, 52 would never have been a diagnostic criteria for metabolic syndrome, and that is why D is the answer. Fourth point, there will be hypertension in the patient. Either systolic blood pressure is more than 130 or diastolic blood pressure equal to or more than 85 millimeters of mercury. And fifth, raised fasting प्लाज्मा ग्लूकोज FPG शॉर्ट में लिख रहा हूं, फास्टिंग प्लाज्मा ग्लूकोज इक्वल टू और मोर देन 110 मिलीग्राम पर डेसीलीटर, इक्वल टू और मोर देन 110 मिलीग्राम पर डेसीलीटर। कब डायग्नोस करते हैं? रिमेंबर, क्राइटेरिया इज ऑल्सो इंपॉर्टेंट। एक क्राइटेरिया से नहीं होता मेटाबॉलिक सिंड्रोम। अगर होता तो आई वुड हैव बीन अ पेशेंट ऑफ मेटाबॉलिक सिंड्रोम। जस्ट अ फ्यू वीक्स बैक आई गॉट माई सेल्फ टेस्टेड एंड इन माई ब्लड HDL कोलेस्ट्रॉल was 36. It is a bad thing, I know, but मेरा बाकी सारा कुछ नहीं था. So based upon one feature, I will not diagnose myself as a metabolic syndrome. How many features should be there? 3 or more features. So 3 out of 5, if present, that will be indicative of metabolic syndrome being present in the patient. Patients who are having metabolic syndrome, they have a high risk of developing both CVS as well as CNS arterial disorders. So they will have high risk of MI, high risk of stroke. Apart from that, these patients are also found to have obesity. They are also found to have acanthosis nigricans. If female, they are found to have high risk of developing PCOD disorder also. And these are the associations of diabetic of metabolic syndrome, which is a PYQ of yourself. All of the following are associations of metabolic syndrome except all of the following are association of metabolic syndrome except this is another PYQ. If technically this is only 4th or 5th question we are discussing, but already we have done about 11 or 12 questions. If you look, go back and see the number of Qs that we are discussing, right? So this is another MCQ. Third MCQ I want to write, which this is an MCQ not of NEET PG, not of FMG, but of NEET PG. And you know that many times NEET PG questions in a high yielding topic get asked there also. I'm not asking you to prepare for NEET PG. What I am saying is one-liner is hot property right now in all the competitive exam. So it will not harm you in remembering. एक line याद रखना है. What is the radiological marker of metabolic syndrome in adults? Now, people are surprised. देखो क्या है कि ये सारी चीजें जो हैं, they are blood based and they all require physical presence. They all require repeated blood testing sometimes. So people are always looking out कि क्या कोई अल्ट्रासाउंड करके डॉपलर करके कैन वी फाइंड अ मार्कर ऑफ मेटाबॉलिक सिंड्रोम व्हिच प्रिडिक्ट्स मोर्टेलिटी मॉर्बिडिटी कार्डियोवास्कुलर रिस्क. ऐसा है and it has been recently added. It is not a part of the diagnosis but radiological marker है which predicts, ब्रैकेट में लिख रहा हूं, it predicts more risk of cardiovascular disease. और ऐसा मार्कर क्या है? when you do ultrasound doppler that shows increased CIMT. What is CIMT? ये रेडियोलॉजी मेडिसिन ओवरलैप है. CIMT stands for carotid intima media thickness. Which carotid are we talking about? Carotid artery we are talking about. देखो हम क्या करते हैं, what we do is, I hope you know that there are two carotid arteries on each side, right? And in carotid artery, every vessel has 3 layers: adventitia, media, and intima. It has been found that patients of metabolic syndrome, the intima and media, their thickness becomes greater compared to non-metabolic syndrome patients. And higher is the thickness, higher is the risk of atherosclerosis. So, आप में मुझ में करके फायदा नहीं है. But if there is a patient of metabolic syndrome, suppose there are 2 patients of metabolic syndrome, दोनों के अंदर आपने किया CIMT, अल्ट्रासाउंड डॉपलर से नेक के अंदर कर लेते हैं, राइट? एक के अंदर वैल्यू हायर आया, सो द पर्सन हु हैज अ हायर वैल्यू विल हैव अ हायर चांसेस ऑफ डेवलपिंग MI एंड स्ट्रोक इन लेटर लाइफ. और जिसका इंटीमा मीडिया थिकनेस कम है इन मेटाबॉलिक सिंड्रोम, उसके अंदर रिस्क कम होगा. इट इज अ वेरी वेरी इंपॉर्टेंट मार्कर एंड इट इज इंक्रीजिंगली बीइंग यूज्ड इन many tertiary care centers in India also. So it is something that you can add in your notes, right? So fatty liver, see, fatty liver is not considered a good marker because fatty liver can occur in the absence of metabolic syndrome as well. I hope you have heard about a disease known as non-alcoholic steatohepatitis, right? So this is metabolic syndrome. Metabolic syndrome, best way to avoid: good lifestyle, which unfortunately doctors don't have. Good workout, which unfortunately doctors don't do. Avoiding alcohol and chola bhatura, which unfortunately doctors don't do. But fourth is trying and resolving that I will do all of these once I crack my FMG exam and start my internship. That you can definitely do, right? So पहले याद करेंगे metabolic, crack करेंगे exam और उसके बाद we'll come back to a healthy lifestyle, because what use money and degrees if you are unhealthy and not being able to enjoy that. आगे चलते हैं. Let us not waste time. Next question. Patient has palpitation, एपिसोडिक हाइपरटेंशन एंड डायाफोरेसिस. डायाफोरेसिस क्या होता है? डायाफोरेसिस वर्ड बार बार आता है. डायाफोरेसिस मींस एक्सेस स्वेटिंग इन द पेशेंट. एक्सेस स्वेटिंग इन द पेशेंट. पैल्पिटेशन का मतलब क्या है? व्हेन यू फील कि आपका दिल धड़कता हुआ फील हो रहा है, राइट? पैल्पिटेशन. एपिसोडिक हाइपरटेंशन, कभी कभी हाइपरटेंशन होता है. Which of the following test must be done to identify the cause? So remember the features. In case patient is having palpitation, episodic hypertension and diaphoresis, one possibility you should be suspecting is possibly patient is having pheochromocytoma. Pheochromocytoma is a tumor which produces increased amounts of catecholamines, and these catecholamines are responsible for sympathetic stimulation, producing disease in the patient. So which of the following test must be done to identify the cause? Remember, in increased catecholamine synthesis, the blood level as well as urinary level of metanephrine and vanillyl mandelic acid will be elevated, and so the answer to this question is B. Most of you have got it correct. Absolutely right. Urinary 5-HIAA is done in carcinoid syndrome, whereas this variety is done in pheochromocytoma in the patient, right? So few words, PYQs, which have been asked on pheochromocytoma. Let us do a summary here. PYQs on pheochromocytoma. Unnecessary information nahi padenge. I'm actually fond of this, but PYQs and one-liners, I would say. So most common site, bracket 60% cases, it arises from adrenal medulla. Absolutely right. It arises from adrenal medulla. Second, it can be syndromic, it can be non-syndromic. Most common syndrome associated with pheochromocytoma, it will be MEN2 syndrome. I hope you know that MEN1, MEN2, MEN3, MEN4 are high yielding topics for the upcoming exam. They are always asked. So go through them. They are there in your notes, whatever source you have read it already. Third thing, what is the rule of 10? Rule of 10 found in pheochromocytoma. Rule of 10 in pheochromocytoma. 10% are found to be extra-adrenal. 10% are found to be there in children. 10% are bilateral. 10% are associated with MEN syndrome. MEN syndrome associated. 10% are having asymptomatic. Asymptomatic means incidentally detected. Incidentally detected means किसी और चीज के लिए देख रहे थे और मिल गया. 10% are found to have familial. Familial means family में रन करता है. पापा को भी था, बेटे को भी है और उसके बेटे को भी होगा. And 10% do not have hypertension. 10% do not have hypertension, right? So this is the rule of 10 you need to remember. What is the typical microscopic finding? Microscopic examination में क्या मिलता है? You find a pattern known as Zell-Balan pattern. Again a PYQ. You will find it given in pathology. So Zell-Balan pattern is found in these patients. Yes, Gautam Prakash, absolutely right. SDH gene mutations are responsible for them in familial cases, and they are included in the group of paragangliomas. Absolutely right. Then what is the type of cardiomyopathy? Yes, cardiomyopathy which can occur in pheochromocytoma. It is dilated cardiomyopathy. So dilated, spelling mistake. Dilated cardiomyopathy can occur in patients of pheochromocytoma. Then What is the site of metastasis? Site of metastasis in pheochromocytoma. Most common is lymph nodes, followed by liver, followed by bone, followed by lungs. अलग अलग बुक्स में अलग अलग मिलेगा. This is what is written in Harrison as well as Nelson. Nelson talks about the adolescent age group. Harrison talks about the post-adolescent age group. दोनों के अंदर same है. Lymph node, liver, bone, and lungs in the patient. Then, what are the investigations that you will do? Investigations. First, we will do blood investigation as well as urine investigation. Blood and urine investigation will show increase free metanephrines in blood, which is considered to be a screening test. There will be increased VMA and increased catecholamines in both blood and urine. In both blood and urine. In both blood and urine, they will be found. For imaging, initial imaging of choice is done by CECT or MRI with contrast. And MRI with contrast is considered MCQ NEET PG exam investigation of choice in extra-adrenal pheochromocytoma. Otherwise, adrenal ke andar both are sensitive, right? And what is the typical sign seen on CT scan and MRI? The radiological sign past FMGE PYQ, light bulb appearance. Light bulb appearance is seen in the patient. And for metastasis, spread, we will do PET CT scan. So PET CT scan is done for metastasis and spread. If PET CT scan, if it fails, more sensitive but more costly, we can do a radiological scan known as MIBG scan. MIBG scan. PET CT scan can diagnose even small tumors. Even small tumors less than 1.5 centimeter can be diagnosed. Second is MIBG scan. Third is SRS scan. The SRS scan is nothing but indium 111 somatostatin receptor scan. सोमेटोस्टैटिन रिसेप्टर स्कैन. इसके अलावा बहुत सारे और स्कैन्स भी डिस्क्राइब किए गए हैं, परटेक्नेटेड स्कैन, गैलियम स्कैन, थैलियम थैलेट स्कैन, बट दे आर क्लिनिकली नहीं यूज होते, राइट? क्लिनिकली जो यूज होते हैं वो यही है और इसी के बारे में आपने याद करना है. एंड ट्रीटमेंट ऑफ चॉइस इज ऑलवेज इनिशियल अल्फा प्लस बीटा ब्लॉकेज followed by surgical removal. Followed by surgical removal. Followed by surgical removal. Followed by surgical removal. राइट? तो ये हो गया. अच्छा, मुझे और भी क्वेरीज आ रही हैं. पिछले सेशन में भी आया था और मैं बीच में भी आप लोग दो लोगों ने मुझे पूछा है कि सर एंडोक्रिनोलॉजी आरआर कब करोगे? 100% मंडे तक मैं डाल दूंगा एंडोक्रिनोलॉजी आरआर. 1 घंटे का आरआर होगा. Only one-liners, key topics, case scenarios, just I have discussed for the other systems, right? That I will put up. So Sunday evening या Monday morning आप देख लेना, right? आज का दिन after this session I'm busy. Match नहीं है, patients हैं मेरे. So I have given appointment. So I have to see some patients and all. And after that, yes, obviously the match will be there. I hope most of you will not be watching the match, but just intermittently seeing and supporting Team India, because yes, our wishes are with them. But we have a bigger task to fulfill, that is cracking the exam, right? And apart from that, I will, मुझे याद है, I have to do a small RR. It will be free for all. It will be done on YouTube. But just give me one more day and I will put it up before your exams, right? Remaining RRs I have already done, and this PYQ I'm taking exclusively on Meduhub only, right? और कहीं पर मैंने नहीं किया है. Let us continue. Next question. अगेन दिस इज अ कंट्रोवर्शियल क्वेश्चन और इसका अलग अलग चीज है, बहुत सारी अननेसेसरी इंफॉर्मेशन दिया है, तो इसको सिर्फ समरी फॉर्म में लिखेंगे. सो लुक एट दिस क्वेश्चन. 65-year-old male presented with weakness, lethargy, cold intolerance and sluggish ankle jerk. TFT में हमें क्या मिला? TSH is increased. So ये साइड में लिखते जाओ, समझते जाओ. TSH is elevated. T4 is 0.3, जबकि आप लोअर लिमिट क्या है? 0.6. So T4 is low and T3 is 70, that is 230 to 619, so T3 is also low. So TSH increase, T4, T3 is low, the patient is likely suffering from hypothyroidism. So patient is likely suffering from hypothyroidism. Ark Sharma, जैसे ही सेशन पूरा होगा, give me a reminder. I'll make sure that before I take my dinner, the PDF is there. I upload it, right? आपको कोई भी डाउट्स हैं, आप just message me. I know I'm bad at replying to messages, but I will try my best and be active for the next 10 days because I know exams are around. And my one advice might make a 0.01% difference in your preparation. So those who are not following, Instagram पे मैं daily reply करता हूँ, so you can follow me on Instagram and you can put in a message over there, right? So you can always do that. In case you are not following, in case you are not interested, it is okay, right? But what is more important is revision, revision, revision. नया रैंडम चीजें नहीं पढ़ना है. In case you are planning to leave out, I keep saying, in case you are planning to leave out medicine, ideally notes पढ़ने हैं, उसी को रिवाइज करना है. कोई सिस्टम मेडिसिन में छोड़ा है, उस सिस्टम को रैपिड रिवीजन से करना है. अगर रैपिड रिवीजन नहीं कर पा रहे, आई हैव अ मिनी रैपिड रिवीजन, अल्ट्रा रैपिड रिवीजन आई हैव डन ऑन माय यूट्यूब चैनल, उसको कर सकते हैं. उसको भी नहीं करके जाना, PYQs को एक बार नजर से निकाल दो, बट डोंट गो अनटच्ड. Who knows? One system may give you 4 questions and those 4 questions were all repeat questions. So don't be in that scenario that you left out the entire system, right? So इसके बारे में और बात बाद में करेंगे. So let us continue. So this patient is having TSH increased, T4, T3, hypothyroidism है. We have to start levothyroxine, right? But when you start levothyroxine, age of the patient comes into consideration. So what do the guidelines say? So I am writing here how to start levothyroxine. So rules are very clear. You may get the same question, you may get a similar question with some changes. In case patient is having age less than 60 years, the initial dose is always 50 to 100 micrograms per day. So initial dose is 50 to 100 micrograms per day. Then you increase by 12.5 to 25 microgram every 3 to 4 weeks. If TSH gets suppressed, dose reduction is also done similarly. Similarly का मतलब you will decrease by 12.5 to 25 microgram every 3 to 4 weeks. And once the patient is stable, symptoms are controlled, you will continue on the same dose. Right? मुश्किल नहीं है. Practice में भी यही करते हैं. So tomorrow many of you are going to be interns. And if the patient load is high, have a look at this. And if the patient is in medicine OPD, you are sitting as intern, you get this and same dose चल रहा है, you would be very proud कि सर मुझे याद था और मैंने एग्जाम में अप्लाई कर पाया. Because end of the day, we are going to be doctors, we are going to be treating patients, right? So सिर्फ MCQ नहीं करना है. उसके आगे अगर क्वेश्चन बोले एज ऑफ द पेशेंट इज मोर देन 60 years या कार्डियक पेशेंट ऑफ एनी एज इन हाइपोथायराइडिज्म, दिस इज वेरी वेरी इंपॉर्टेंट. हो सकता है कल को वो बोल दें 40-year-old पेशेंट बट हैविंग अ हार्ट डिजीज, तो उसमें एज मोर देन 60 ईयर वाला कट ऑफ को यूज करेंगे. व्हाट डू द गाइडलाइंस से? यू स्टार्ट थायरॉक्सिन मोर केयरफुली. यू विल बी स्टार्टिंग द इनिशियल डोज ऑफ levothyroxine will be 25 micrograms per day, right? And you will increase by 12.5 microgram every 3 weeks and titrate मतलब घटाएंगे and बढ़ाएंगे based upon TSH value. And this is your past PYQ 2017, पुराना हो गया, I know, but MCQ is an MCQ. Which parameter is used to monitor a hypothyroid patient on therapy? Remember, serial TSH, not T3, not T4. Serial TSH is used for monitoring and titrating therapy in hypothyroidism. Right? This is another one-liner. Please add it to your course. Please add it to your course. Yes, Pratyusha, right? आपने अच्छे से डिटेल में पढ़ा है, which is good. So answer to this question is start levothyroxine at 25 microgram and increase the dose gradually. C is your answer. Okay, अब ये याद कर लो, एक बार एग्जाम में जाने से पहले इसको पढ़ के जाना. राइट, लेट्स गो टू द नेक्स्ट क्वेश्चन. हर बार जब मैं कोई भी सेशन लेता हूँ मेडिसिन का, पीडियाट्रिक्स का, लोग पूछते हैं कि सर इसमें से कुछ आएगा. इफ आई हैड सो मच ऑफ गुड वो यू नो, तो मैं डॉक्टर नहीं बनता, मैं एक इन्वेस्टर बनता और मैं स्टॉक मार्केट में अपना स्किल को यूज करता, एंड आई वुड हैव मेड मिलियंस. सी द फैक्ट इज नोबडी कैन प्रिडिक्ट, बट वन थिंग कैन बी प्रिडिक्टेड इज every system will give you something, and it is usually the commonly asked things which are asked again and again, and we make mistakes in those. So close to the exam, revise common things commonly asked, commonly ignored, and commonly lead to downfall in the exam. ये चीज याद रखें. Right, let us move further. Which of the following is not a component? It is not a component of child book score. आसान है. So we need to first see what are the components of child pug score. Child pug score, also known as child pug Turcot score. So child pug बोले या child pug Turcot बोले या CPT score बोले, they are all referring to the same score. So what are the components of child pug Turcot score? There is a mnemonic for that. Components. There is a mnemonic for that. एक चाइल्ड को क्या चाहिए? एन एजुकेटेड बाप. एक बच्चे को चाहिए एजुकेटेड बाप. सो चाइल्ड टर्कॉट पर्क स्कोर के 5 कंपोनेंट हैं, ए ई बी ए पी. What does A stand for? A stands for albumin, that is serum albumin we are talking about. E stands for encephalopathy in the patient. B stands for bilirubin in the patient. So serum bilirubin is being talked about. A again stands for ascites, and this P stands for prothrombin time. In case prothrombin time is not available, INR can be used, but prothrombin will always be the better answer in case of the patient. And what is the use of child pug score? It is used to indicate, it indicates and predicts mortality and need for liver transplant in chronic liver disease patients. Chronic liver disease patients. Right? Put a star and write 2 important one-liners. Pehla one-liner. When child pug Turcot score, CPT score, is used in non-alcoholic CLD. What is CLD? Chronic liver disease. अभी हमने पढ़ा. Non-alcoholic CLD, INR is used instead of prothrombin time sometimes. It's a very, very important point. And second point, what is the most common indication for liver transplant? अगर बोले adult, your answer will be cirrhosis. And if the MCQ says child, your answer will be EHBA. What is EHBA? Extrahepatic biliary atresia. This is a NEET PG question. This is a FMGE MCQ. So इसके अंदर हमारा एक क्वेश्चन जो ये क्वेश्चन है, और 2 और 3 और 4, ये 4 क्वेश्चन हैं जो चाइल्ड टर्कॉट स्कोर से they have been asked in the past. Apart from that, when you are doing revision, the other scores like MELD score, pediatric MELD score, Naser score, they are also very important. It is a very high probability that some scoring system will be asked to you in the exam. So scores like Q-SOFA score like Glasgow Coma Scale, and scores like hepatic scoring system are almost sure things for your exam. There is another scoring system we use in stroke patients, ABCD2 score, उसको भी ऐड करना है. So 6 और 7 scores है मेडिसिन में. Be thorough with it, be master of it. अगर आपको लगता है कि बहुत ज्यादा हो रहा है, पढ़ने का मन नहीं कर रहा है, यू आर हैविंग डिनर, यू वांट टू रीड समथिंग जो श्योर आएगा, लेकिन लेजरली पढ़ना है, रीड स्कोर्स टुडे, एंड यू कैन बी क्वाइट श्योर कि कुछ ना कुछ डायरेक्टली इनडायरेक्टली जरूर आएगा, राइट? सो दिस इज समथिंग आई वांटेड टू शेयर. लुक एट द नेक्स्ट क्वेश्चन नाउ. अब इसमें मैं बहुत सारे पीवाईक्यूज करूंगा, बच्चों के भी और एडल्ट के भी. सो पेशेंट प्रेजेंटेड विद प्रोग्रेसिव पेरी ऑर्बिटल इडीमा with 4 plus urine protein. All of them, all the questions I have written, I have typed there are PYQs. They are, none of them is a framed question, right? So progressive periorbital edema with 4 plus urine protein but no hematuria. Which of the following drug is the first line indicated therapy in the patient? सबसे पहले तो बताओ भाई, डायग्नोसिस क्या है? डायग्नोसिस क्या है? What is the diagnosis? The diagnosis in the patient is suffering from nephrotic syndrome. Nephrotic syndrome, right? What nephrotic syndrome? And in case patient is having nephrotic syndrome, so there is 4 plus massive proteinuria is present. 3 plus or 4 plus urine protein is nephrotic syndrome. What is the initial drug of choice? Initial drug of choice. It is always steroids. Which is the best steroid used? It is oral prednisolone. Oral prednisolone. Right? So answer to this question is B. Let us do some one-liners and PYQs for your exams. Let us do it in a very different way so that it is easy for you to understand. देखो MCQ सॉल्व होना चाहिए, नहीं तो बड़ी बड़ी बातें करके फायदा नहीं है, राइट? सो याद करते हैं. If the question says child 3 plus or 4 plus urine protein, child having 3 plus 4 plus urine protein, no hematuria, no hypertension. So what is the likely diagnosis? Patient is having primary nephrotic syndrome. Primary nephrotic syndrome. Primary nephrotic syndrome, the histopathological correlate of this is called as minimal change disease. Minimal change disease. Why do we call it as minimal change? ये देखना है क्वेश्चन के अंदर. January 23 में इसके ऊपर केस सिनेरियो came. Many students got it wrong in the exam because they did not see what was being asked. Light microscopy पूछ रहे हैं या electron microscopy पूछ रहे हैं? Remember that on light microscopy, normal glomeruli will be seen. That is why we call it as minimal change. No change is seen, no inflammation is seen. And that was the answer. Electron microscopy में you will find effacement of food process of podocytes. Food process of podocytes. पुनीत शर्मा, ये चाइल्ड की बात हो रही है, एडल्ट पे मैं भी आऊंगा. आई विल क्लैरिफाई, डोंट वरी, राइट? तो इसके अंदर व्हाट विल बी द ड्रग ऑफ चॉइस? इट विल बी prednisolone, and these patients will show excellent response to steroids. They will show excellent response to steroids, right? Pehla point. Second point, if question says adult patient who's having 3 plus 4 plus urine protein or 24-hour urine protein excretion more than 3.5 grams per day, more than 3.5 grams per day, with or without hypertension, hematuria, with or without, may or may not be present, so the patient is having nephrotic syndrome. But ये primary secondary वाला जो फंडा है, it is not very popular in clinical setting of a adult patient with nephrotic syndrome. Now in nephrotic syndrome, if MCQ says, if the question says HIV positive patient or past history of UTI, क्वेश्चन में मेंशन कर देगा, और क्वेश्चन बोलेगा पास्ट VUR, व्हाट इज VUR? वेसिको यूरेट्रिक रिफ्लक्स, या बोलेगा पास्ट सर्जरी डन on the urinary, on the kidneys or on the urinary tract. In such patient, the likely histopathological correlate is going to be FSGS, focal segmental glomerulosclerosis. Got it? If question says age more than 65 years or drug associated nephrotic syndrome or malignancy, for example, CLL or CML is present in such patient, what is the likely diagnosis going to be? Membranous glomerulonephritis. This is an MCQ. You can check. It is given in FMG Solutions book also, obviously as a case scenario. This is an older MCQ. This one is an MCQ asked in January 24 exam. And what happens to the, what is the drug of choice and the response to steroid? Identify incorrect. In pediatric part, you will find question. So apart from this question, these are the 4 questions which have been asked, and similar case scenarios can be asked to you in the exams as well. In the end, see, IgA nephropathy is not a cause of nephrotic. वो nephritic करता है, nephritic करता है, याद कर लो, right? If the MCQ says, what is steroid resistant nephrotic syndrome? Steroid resistant होगा, no response to steroids used for, I'm writing with a colorful pen, 6 weeks. No response to steroids used for 6 weeks. The likely diagnosis in the patient is going to be, the patient is likely to have steroid resistant. Drug of choice in such patients will be calcineurin inhibitors. Calcineurin inhibitors. And which calcineurin inhibitor will be used here? Tacrolimus will be used, followed by cyclosporin. That will be the answer. That will be the answer. Right? अब क्योंकि आपने पूछा है तो मैंने अगले क्वेश्चन पे जाने से पहले इस टॉपिक को क्लैरिफाई करके खत्म कर देते हैं, राइट? बिकॉज वी आर डूइंग रिवीजन हियर. तो ये तो हुआ नेफ्रोटिक की बात. इफ एमसीक्यू सेज edema with 2+ urine protein or urine protein is mild to moderate, bracket not massive, plus hematuria, hypertension, oliguria sometimes. In such patients, the likely diagnosis is going to be acute nephritic syndrome. Acute nephritic syndrome. याद कर लो ये acute nephritic syndrome. तो difference क्या है? Proteinuria difference है. Massive proteinuria is nephrotic with subvarieties. Mild to moderate proteinuria with our hematuria is nephritic. आज के बाद गलत नहीं करना है. Simple रखो. Massive proteinuria is nephrotic with subtypes. Non-massive proteinuria हो रहा है but massive नहीं है, with hematuria is nephritic. If you keep it like this, you will not go wrong in the exam. तो अगर ये mention कर दे और पूछे क्या diagnosis नहीं हो सकता, your answer will be minimal change disease cannot be the answer because minimal change disease is nephrotic syndrome. Got it? पहला तो this is the first thing to understand. Now there are some causes. How to identify the causes? We are not talking rare causes here, right? Acute nephritic syndrome is often triggered. It is often triggered by infection, right? तो कैसे याद करेंगे? Question says infection followed by 1 to 5 days later there is onset of acute nephritic syndrome. The likely diagnosis is going to be IgA nephropathy, also called as Berger's disease. And if there is 1 to 3 weeks later, ये यानी कि 7 to 21 days later, there is onset of nephritic syndrome, hematuria, proteinuria, अब दो पॉसिबिलिटी है, पहला है PSGN और दूसरा है HSP नेफ्राइटिस। व्हाट इज HSP? हैनॉक शॉनलेन परप्यूरा। कैसे करोगे कि क्या है? PSGN के अंदर आइसोलेटेड नेफ्रेटिक सिंड्रोम होगा, देयर विल बी, एंड दीज पेशेंट्स विल हैव लो सीरम C3, will be clue. There will be raised ASO as well as anti-DNase B titers in the patient. HSP nephritis में also called as IgA vasculitis. There will be palpable purpura, GIT, and joint involvement will be clues. And biopsy will show the presence of mesangial IgA deposits in the patient. mesangial IgA deposits present होंगे, mesangial IgA deposits will be present in the patient. तो याद कर लो, ट्रीटमेंट देखो सभी का जनरली हम देते हैं स्टीरॉइड्स, बट इन सिलेक्टेड केसेस स्टीरॉइड्स आर इफेक्टिव बट दे हैव साइड इफेक्ट्स, और PSGN के अंदर स्टीरॉइड्स का कोई रोल नहीं है, तो यहाँ पर ये लिख सकते हो PSGN इज नो रोल ऑफ स्टीरॉइड्स, दे हैव गॉट नो रोल ऑफ स्टीरॉइड्स, राइट। और HSP नेफ्राइटिस में देते हैं ओनली व्हेन इफ देयर इज अ सीवियर डिजीज इन द पेशेंट और देयर इज अ सीवियर GIT इन्वॉल्वमेंट इन द पेशेंट, राइट। सो ये है आपका की फीचर्स। गुड पेस्टर सिंड्रोम में हेमेचूरिया विद हिमोप्सिस होगा। सो अगर बोले अगर बोले हेमेचूरिया विद हिमोप्सिस, व्हाट इज हिमोप्सिस? कफ में देयर इज ब्लड विच इज कमिंग, राइट। हेमेचूरिया प्लस हिमोप्सिस, थिंक ऑफ गुड पेस्टर्स, याद कर लो। बहुत सारे MCQs हो रहे हैं हमारे कवर, PYQs ही हो रहे हैं। if you have solved the question, you would know what I mean by saying that multiple PYQs are being discussed. We are covering a lot of ground here. एक और दिमाग में चीज आया, अगर एग्जामिनर बोले I don't have space here, okay, I'll try to fit in somewhere, okay, I'll fit in here, साइड में लिख रहा हूँ। if examiner says familial हेमेचूरिया का मतलब फैमिली हिस्ट्री है, सबको हेमेचूरिया होता है, with sensory neural hearing loss with eye involvement in the form of lenticonus, we call it as anterior lenticonus of the eye, तो पेशेंट के अंदर डायग्नोसिस होगा एल्पोर्ट सिंड्रोम। एल्पोर्ट सिंड्रोम विल बी द डायग्नोसिस, राइट। तो ये भी अगले से आपका PYQ। तो अभी तक हमने क्या पढ़ा, ये आप दिस वीडियो विल बी अवेलेबल ऑन द चैनल ऑफ मेडूहब, सो यू कैन हैव अ लुक एट इट अगेन विद 2x screen, 2x speed. You can add the points in case you want later. So massive proteinuria is nephrotic with subtypes. Mild to moderate proteinuria with hematuria is nephritic with subtypes. Look for the keyword, rule out option, and you will always reach the correct answer. Okay, आगे चलते हैं। Which of the following is not a feature of Parkinson's disease? Which of the following is not a feature of Parkinson's disease? Have a look and give me your answer. Which of the following is not a feature of Parkinson's disease? What is the answer? Yes, Jaya and Pratyusha, absolutely right. Anterior lenticonus is anal port, posterior in Lowe syndrome, also called as oculocerebrorenal syndrome. Good. हैरी कौशिक, वेजेनर्स और वैस्कुलाइटिस जो है मैं मिसलेनियस टॉपिक में डिस्कस करूंगा, I'll be releasing soon. What is the answer here? Diplopia, absolutely right. Hypophonia due to involvement of the vocal cords and the nerves can sometimes happen. Rigidity, bradykinesia leading to freezing are the hallmark features of Parkinsonism, but diplopia does not occur in most patients of Parkinsonism. By ruling out the options, you can correctly reach the answer. It is a PYQ. तो कब you will suspect Parkinson disease in the patient? As the case examiner will say, adult patient, mask-like expressionless face, rigidity, tremors at rest, and bradykinesia, unstable posture, reduced blinking, drooling of the saliva, autonomic disturbances like fluctuations in BP, fluctuations in sweating, fluctuations in heart rate, and shuffling gait is present in the patient. So in such patients, the likely diagnosis is going to be Parkinson's disease. Parkinson's disease predominantly involves which part of the brain? It predominantly involves basal ganglia involvement. Basal ganglia involvement. So what is the pathological hallmark of Parkinson disease? The pathological hallmark is death or degeneration of dopamine producing, that is dopaminergic neurons, where in the substantia nigra pars compacta region of the striatum, that is basal ganglia, right? So degeneration of dopaminergic neurons in the substantia nigra pars compacta. Additional PYQ, you need to remember. Additional PYQ. Treatment part में मैं नहीं जा रहा हूँ. You have already read in details in your pharmacology also. So PYQ, early onset Parkinsonism. Early onset Parkinsonism along with hepatomegaly or eye involvement, the likely diagnosis is going to be Wilson's disease. Remember, Wilson's disease. And Wilson disease is also known as hepatolenticular degeneration. Hepatolenticular degeneration. Yes, absolutely right. आपने ठीक बोला. Parkinson disease के अंदर many times you have the alpha synuclein, that is SNCA gene mutations are found. In fact, pathology के अंदर this is also a past PYQ. It is also a past PYQ. And eye involvement typically occurs in the form of KF rings or sunflower cataract. Or sunflower cataract in the patient. Let us move further. Look at this question. 45-year-old male patient, actual MCQ, presented to ER emergency room with hemiplegia of left side of the body started 8 hours ago. So it is looking like a stroke which has happened in the patient. Hypertension is there. NCCT had revealed a large intracerebral bleed on one side of the basal ganglia. Which of the following needs to be done? Remember that when any stroke patient comes to you, after airway breathing circulation, do a urgent CT scan, non-contrast CT scan, and look for bleed. If bleeding is present, that is a hemorrhagic stroke. Management is totally different. Usually they are hypertensive and no thrombolysis should be done. In case bleeding is not present, in such patients, you will consider alteplase as the therapy. Thrombolysis will be considered in the patient. So which of the following needs to be done? ध्यान रखो, this is hemorrhagic stroke. So what is the diagnosis in the patient? Hemorrhagic stroke. In a hemorrhagic stroke patient, thrombolysis is contraindicated. Thrombolysis is contraindicated. And देखो thrombolysis इसलिए भी, अगर ये नॉन हेमरेजिक होता तो भी हम thrombolysis नहीं करते, बिकॉज उसका विंडो पीरियड होता है 4.5 to 6 hours up to, right? So thrombolysis is contraindicated anyways. So in patient के अंदर हमारा this cannot be the answer. Heparin has no role in the management of stroke. Wait and watch stroke का patient है, wait and watch थोड़ी करेंगे. So what are we left with? Either you know the answer correctly or you can reach the answer by ruling out other option. So BP management is the initial goal in patient of hemorrhagic stroke. Stroke management के ऊपर case scenario question आते हैं. People get it wrong in the exam. Because we are very close to the exam, तो मैं आलतू फालतू चीजें नहीं बताऊंगा. I will be writing the key points, the key words. So any patient, so stroke MCQs. I'm giving the heading. Sorry, giving the heading stroke MCQs. Management. How to remember the management. So any patient who comes to you with acute onset neurological deficit. For example, hemiplegia, hemiparesis, dysarthria, और माउथ डेविएशन ऑफ द माउथ. इनमें से कुछ भी प्रेजेंट है, एक्यूट ऑनसेट है. सो यू शुड सस्पेक्ट स्ट्रोक, और टीआईए. हमें पता नहीं ना, अभी तो पेशेंट इज जस्ट प्रेजेंटेड. टीआईए इज ट्रांजिएंट इस्चेमिक अटैक. ओके, तो ऐसे पेशेंट में व्हाट इज द मैनेजमेंट यू आर गोइंग टू डू? फर्स्ट थिंग, एयरवे, ब्रीदिंग, सर्कुलेशन. फुल नहीं लिख रहा हूं, एयरवे, ब्रीदिंग, सर्कुलेशन. गेट अ अर्जेंट NCCT, नॉन कंट्रास्ट सीटी स्कैन ऑफ द हेड डन. दो पॉसिबिलिटीज होंगी. CT scan shows hemorrhage, but second possibility, no hemorrhage. No hemorrhage. If hemorrhage is present, that is labeled as hemorrhagic stroke. That is labeled as hemorrhagic stroke. Hemorrhagic stroke, majority of these patients, they are hypertensive. And the site of bleed is generally in putamen. What is the most common site of bleeding in hypertensive hemorrhagic stroke in the patient? PYQ, please add it. One-liner PYQ asked in the exam, already asked in the exam. So site of bleed is putamen. What is the management to be done in such patients? Remember that thrombolysis is contraindicated. So what is the mainstay of therapy? Do BP control, do raised ICP management. If large cerebellar bleed or hematoma size is more than 3 centimeter, plan neurosurgical evacuation. Evacuation means surgery करेंगे, hematoma को surgically remove करेंगे. You will plan a neurosurgical evacuation in the patient. On the other hand, if there is no hemorrhage in the patient and it is a stroke, it is likely to be a thromboembolic stroke in the patient, right? उसको लेबल नहीं करते, no hemorrhagic है, तो हमें नहीं पता थ्रोम्बस से, एम्बोलस से या किसी और रीजन से है. तो हम क्या करेंगे कि पीरियड कितना हुआ है स्ट्रोक को आए. तो दो पॉसिबिलिटीज होंगी. विंडो पीरियड is less than 4.5 to 6 hours. Less than 4.5. And second possibility, window period. देखो आइडियली लेस देन 4.5 होता है. समटाइम्स इन अवर रिसोर्स लिमिटेड सेटिंग अप टू 6 भी ले लेते हैं. एंड सेकंड पॉसिबिलिटी, विंडो पीरियड इज मोर देन 6 hours. राइट, तो विंडो पीरियड लेस देन 4.5 to 6 hours. ऐसे पेशेंट में व्हाट इज द थेरेपी ऑफ चॉइस? डू थ्रोम्बोलाइसिस. Do thrombolysis. Yes, if cerebral edema will be there will be raised ICP. तो ऐसे पेशेंट में हमें मैनिटॉल देना पड़ेगा, ऑस्मोटिक डायूरेटिक देना पड़ेगा. एब्सोल्युटली राइट. पुनीत, प्रत्यूषा, जया, गौतम, हैरी, ऑल ऑफ यू आर डूइंग गुड, आंसरिंग गुड. बट कोई फायदा नहीं है अगर आईपीएल में रन बना लिया और एक्चुअल मैच में नहीं बनाया. सो मैन, लाइफ गिव्स यू अपॉर्चुनिटी. बी लाइक अक्षर पटेल, नॉट लाइक, अभी तो यंग आदमी है बट चल जाएगा. Don't play like Dubey, right? So Shivam Dubey I'm talking about, but he's a young player. He will learn. Let's see if he does something today or not. So window period less than 4.5 to 6 hours. Do thrombolysis. And what is the agent of choice? Alteplase. Alteplase. Suraj Kumar, stroke management, Parkinson disease is useful for any entrance exam. And you can ask your FMG friends. I have discussed FMG MCQs majorly, but in between I have sneaked in some NEET PG past MCQs also. So no harm in listening to it. So do thrombolysis, alteplase, and if it fails, then you can go for mechanical thrombectomy. Mechanical thrombectomy. Suraj Kumar, yes, it is useful for NEET PG. Right? आगे चलते हैं. And window period more than 6 hours. ऐसे पेशेंट के अंदर वी विल चेक the perfusion, check the cerebral perfusion status, and consider endovascular revascularization or mechanical thrombectomy. Mechanical thrombectomy will be considered in the patient, right? So this is the key summary of stroke management cases if you get in the exam. पुनीत शर्मा, कंट्री को भी सपोर्ट करना है, पॉजिटिव रहना है, और अपने आप को भी सपोर्ट करना है एग्जाम के लिए, राइट? सो लेट्स थिंक पॉजिटिव, स्टे पॉजिटिव, होगा वही जो होना है. इफ वी स्टार्ट थिंकिंग नेगेटिव तो वैसे ही मूड खराब हो जाएगा. जब मूड खराब होगा तो देखा जाएगा, राइट? सो इवन इफ इंडिया डज नॉट डू वेल, वी ऑल प्रे इंडिया विंस टुडे. इफ इंडिया डज नॉट विन टुडे, कोई बात नहीं, हम एफएमजी में विन करेंगे, राइट? लेट्स बी क्लियर. आगे चलते हैं. Next question. Which of the following JVP finding will you suspect in a patient with muffled heart sound, hypotension, and raised jugular venous pressure? So what are we looking at? First of all, look at the three things and tell me the diagnosis. So patient is having muffled heart sound, hypotension, and raised JVP. This is nothing but Beck's triad. This is nothing but Beck's triad. And Beck's triad is seen in which patient? Cardiac tamponade. So patient is having likely cardiac tamponade. And cardiac tamponade, what is the typical JVP wave abnormality you will find? There will be isolated, absent, Y descent. And that is the answer. What is cardiac tamponade? Large, massive pericardial effusion which restricts the filling of ventricles during diastole. That is called as cardiac tamponade. It can be traumatic or it can be infectious. What are the key points you should remember? Cardiac tamponade is characterized by Beck's triad that we have already done. So this is the first thing. Second thing to remember, there is raised JVP, but it is non-pulsatile. Non-pulsatile raised JVP, pulsate nahi karta hai. Thirdly, patient will be having a low ECG voltage because fluid is present around the cardiac tissue. So it will impede any transmission of the waves. So low ECG voltage will be there. Fourthly, there will be prominent X descent with absent Y descent. Absent Y descent. Kussmaul's breathing will be absent. It is useful to rule out other conditions. So Kussmaul sign is always absent. Some patients can show abnormality known as electrical alternance. Electrical alternance will be present. When you do echocardiography, you will find a small RV, right ventricular cavity size. Small right ventricular cavity size. Eighth, there will be equalization of diastolic pressure in both the ventricles. Normally it is not there. Equalization of the pressures. And there is a variety of cardiac tamponade known as high pressure tamponade. There is also a variety known as low pressure tamponade. So high pressure tamponade may sometimes have pulsus paradoxus. Remember that pulsus paradoxus is not characteristic of such patients. So they may have. So कौन सी variety of tamponade में हो सकता है? High pressure tamponade can sometimes have. And treatment in the patient, yes, it is always pericardiocentesis. Pericardiocentesis. Very, very high yielding topic. Something on JVP, something on these topics like restrictive cardiomyopathy, constrictive pericarditis, cardiac tamponade, MI. Almost sure hota hai. So going to the exam, running short on time, at least have a look at the key points, keywords. You can get a one-liner. They can make a case scenario and tell you the diagnosis, ask you the diagnosis, or they can ask you in cardiac tamponade, all of the following are seen, except. So you need to remember them with high accuracy in the exam, right? So ये सारे features हैं. Summarize किया है. Answer to this question is D, absent Y descent. Let's go further. 80-year-old diabetic male presented with acute onset chest pain. तो डायबिटिक पेशेंट है, ओल्ड एज है, चेस्ट पेन हो रहा है 20 मिनट से. योर बॉय, देखो अगर आपका तैयारी अच्छा है, आंसर सही हो जाता है, इट इज एन इजी पेपर. If you don't do well in the exam, it's a tough paper. So toughness level varies according to our preparation also sometimes. So what shall be the immediate next diagnostic investigation to do? अगला क्या करना चाहोगे? What is your answer? बड़ा बड़ा इंटरेस्टिंग क्वेश्चन है ये. केस सिनेरियो है और हम गलत करते हैं इसमें. प्रत्युषा, जया, आप दोनों का आंसर गलत है. मैंटिस इज राइट. मैंटिस इज राइट. देखो जो टॉप करता है ना एग्जाम में, उसको कहता है इतना आसान पेपर, राइट. जिसका नहीं होता है वो कहता है यार हमारे हाल से दुश्मनी है एग्जामिनर की. देखो दुश्मनी हो सकती है, उसको रूल आउट नहीं कर सकते आफ्टर द रिसेंट थिंग्स विच यू हैव सीन. बट even worst paper 10% people are passing na. Why are we not among those 10%? We can be, we should be, we will be. So पॉजिटिव रहना अगले 10-15 दिन, है ना. 10-15 दिन इसलिए कह रहा हूँ कि ऐसा नहीं कि उसके बाद डिप्रेशन में चले जाओ. स्टूपिड मिस्टेक, सिली मिस्टेक सब करते हैं. वी हैव टू बी मिनिमल एंड फ्रूगल इन दैट, राइट. मोर अबाउट इट बाद में बात करेंगे. लेट अस स्टिक टू द एकेडमिक्स हियर. सो ईसीजी करेंगे सबसे पहले, उसके बाद कार्डिक बायोमार्कर करेंगे. सो व्हाट इज द अप्रोच to acute coronary syndrome? What is acute coronary syndrome? Whenever there is interruption of blood supply to heart, the chest pain and related features which appear like angina, MI, they are considered as a group of condition, acute coronary syndrome. Yes, Jaya, 1 week, sorry. But उसके बाद भी डिप्रेशन में नहीं जाना है, उसके बाद खुश रहना है. बी पॉजिटिव. अप्रोच टू एक्यूट कोरोनरी सिंड्रोम. What is the hallmark of such patient? The hallmark of such patient is chest pain. You will pass. No, no. You will pass. You have to pass. You have to pass. ऑप्शन नहीं है भाई. मैं पास करूंगा नहीं, मैं पास होके रहूंगा. मेरे पास ऑप्शन नहीं है. दिस इज समथिंग यू नीड टू नो. सो आगे चलते हैं. हॉलमार्क चेस्ट पेन. तो पेशेंट आए आपके पास, फर्स्ट स्टेप टू डू ईसीजी. डू ईसीजी, राइट. दो पॉसिबिलिटीज होंगी. नो नॉन एसटी सेगमेंट एलिवेशन, नो एसटी सेगमेंट एलिवेशन, and second will be ST segment is elevated. ST segment is elevation. Not ST segment and ST segment elevation. अब अगर ST segment elevation है तो ऐसे पेशेंट में the diagnosis is ST segment elevation M, right? If it is non-ST segment elevation, do the second step. Now do cardiac biomarkers. In case you find that cardiac biomarkers are normal, the patient is likely having unstable angina. And in case patient is having a raised cardiac biomarkers, I hope you know the cardiac biomarkers, CKMB, troponin C, troponin I, right? In such patient, it will be non-ST elevation. और इसके अंदर भी do cardiac biomarkers for confirmation. Do cardiac biomarkers for confirmation. हैरी कौशिक, शादी भी डिले हो रही है, कोई फर्क नहीं पड़ता यार. शादी 1-2 साल बाद भी हो जाएगी, कोई दिक्कत नहीं है. ऐसा देखो, एक तो वैसे भी कोई योर डीएनए इज नॉट दैट इंपॉर्टेंट. व्हेन आई से योर डीएनए, आई जस्ट मीन योर, माइन और समबडी एल्स डीएनए. इतना वो नहीं है ना कि कोई स्पेशल हमारे अंदर वो है कि लॉस्ट हो जाएगा जीन पूल. यस, शादी करेंगे, आगे बढ़ेगा, हमारा प्रोजेनी आएगा. There is time for that, but yes, you are right in one way that everything gets delayed in case you don't get selected. But at the same time, life मौका देता है दोस्त. You get time to recoup. मैंने अपने लाइफ में बहुत सारा गलत काम किया है, टाइम वेस्ट किया है. I have sit in exam, got a rank, dropped out to not get selected and sit at home forcefully. वो काम किया है. I wasted. But when the life gave me opportunity, मैंने रैपिडली काम किया है, वहां पर काम किया है जहां पर लोग 1 साल 2 साल में करते हैं, 3 साल में करते हैं, मैंने वो 1.5 साल में किया है. सो आज I have covered up for whatever loss of time had happened in my earlier part of my adolescent and early adulthood period. So what you are doing, what you have done so far, learn from it, but at the same time focus on not repeating the mistake and clearing the exam as soon as possible. Right? तो life मौका देता है आपको to make up for the time which you have lost somehow. But एग्जाम, एफएमजी एग्जाम, बिफोर न्यू रेगुलेशंस कम और कुछ और स्टार्ट हो जाए, जल्दी से क्लियर करो विद अ गुड रैंक, गेट इनटू इंटर्नशिप एंड बी अ पार्ट ऑफ द सिस्टम फास्ट. राइट? तो याद कर लो, फर्स्ट स्टेप ईसीजी होता है, सेकंड स्टेप कार्डियो बायोमार्कर होता है. और अगर आपसे पूछें कि व्हाट इज द बेटर इन्वेस्टिगेशन, द बेटर इन्वेस्टिगेशन, पहला और दूसरा नहीं पूछ रहे तो इट विल ऑलवेज बी कार्डियक बायोमार्कर्स. कार्डियक बायोमार्कर्स कौन सा कब राइज करता है, क्या सीक्वेंस है, सेंसिटिविटी, स्पेसिफिसिटी, दैट आई हैव डिस्कस्ड ऑलरेडी इन अ यूट्यूब सेशन, फ्रीली अवेलेबल ऑन यूट्यूब, तो आप उसमें से देख सकते हो. रिपीट नहीं करेंगे, रेपिटेशन नहीं करेंगे. कार्डियक बायोमार्कर्स मोर देन ईसीजी. राइट? यस, एब्सोल्युटली. संघर्ष करना है यार. हम देखते हैं ना, हमें दिखता है यार ये आदमी या दिस पर्सन इज सो मच वो. आई टेल यू ऑनेस्टली, हम सब एक जैसे हैं. हम सब एक जैसे हैं. फर्क इतना है कि हम लोग जो आपको पढ़ा रहे हैं इस वक्त, we have gone through the same milestones as yours. We made mistakes. We had so-called fucked up life as well. We did a lot of stupidity in our life, but we learned from it. God was kind, nature was kind, and we were able to cross the line and come on this side. जब लाइन क्रॉस कर जाते हैं तो लगता है कि नहीं यार इतना मुश्किल नहीं था. But when you are on the other side, I had the same problems as you. Right? Maybe I was not exactly same problems, but we have all gone through the similar problems. तो ऐसा नहीं है कि God आपके साथ ही unkind है. At the same time, whatever situation you are in, ask yourself what I can do to come out of that. Right? ये मत पूछो कि नेचर ने मेरे साथ क्या किया, ये पूछो मैं क्या कर सकता हूँ. 7 days, अगले 7 days के अंदर जान लगा दो. जो सिस्टम या टॉपिक नहीं पढ़ा है, एक बार नजर से निकाल दो और लास्ट 48 आवर में दोबारा से एक बार देख लो जो लास्ट 5 days में पढ़ा है. याद रहेगा एग्जाम में, बिकॉज एमसीक्यू विल हैव ऑप्शन रिटन देयर. पहचानना है, शॉर्ट नोट नहीं लिखना है. राइट? आगे चलते हैं, आगे चलते हैं. Which among the following, which among the following is the most common cause of Cushing syndrome in a 68-year-old male? PYQ. आगे चलते हैं, जल्दी बोलो. Which among the following is the most common cause of Cushing syndrome in a 68-year-old male? What is the answer? जल्दी जल्दी जल्दी. देखो, एक्टॉपिक सीआरएच प्रोडक्शन तो बहुत ही रेयर है, मैंने देखा ही नहीं आज तक, सुना भी नहीं किसी को. एक्टॉपिक एसीटीएच प्रोडक्शन होती है कुछ पैरान्यूप्लास्टिक ट्यूमर्स के अंदर. ट्यूमर्स आर नॉट दैट कॉमन. एड्रिनल कार्सिनोमा, अगेन वेरी रेयर थिंग. ये ब्रेन के ट्यूमर्स कॉमन होते हैं, एंड दे हैव अ टेंडेंसी टू प्रोड्यूस लार्ज अमाउंट ऑफ एसीटीएच. एंड सो द आंसर टू दिस, look at the table and then we come here. My dear friends, causes of Cushing syndrome, ये टेबल है हैरिसन का. कुशिंग सिंड्रोम दो तरह का होता है, ACTH डिपेंडेंट which is 90% and ACTH independent which is 10%. राइट? अब ACTH डिपेंडेंट जो होता है ये दो तरह का होता है, कुशिंग डिजीज एंड एक्टोपिक ACTH प्रोडक्शन. व्हाट इज कुशिंग डिजीज? which is due to pituitary adenoma producing ACTH. This comprises 75% of all Cushing syndrome patients, and so this is the most common cause of Cushing syndrome in the patient. भाई साहब, pituitary microadenoma is the answer. Many of you are getting it right, my dear friends. इसीलिए आर एंडोक्रिनोलॉजी में कुशिंग सिंड्रोम और उसकी डायग्नोस्टिक अप्रोच, कुशिंग, कॉन, एडिसन, डायबिटीज, ये सारे टॉपिक करेंगे डिस्कस. रिकॉर्डेड होगा, लाइव नहीं डालूंगा, रिकॉर्डेड होगा सो दैट यू डोंट वेस्ट टाइम, आई डोंट वेस्ट टाइम. But please go through it in case you have not read endocrinology properly. Answer to this question is D, that is pituitary microadenoma. ये टेबल है, याद कर लो, बहुत इंपॉर्टेंट टेबल है. इस टेबल से प्रिसाइजली क्वेश्चन उठा के डालते हैं. देखो, कुशिंग सिंड्रोम दो तरह का होता है. व्हाट इज कुशिंग सिंड्रोम? एक्सेस ऑफ कॉर्टिसोल. राइट? एक्सेस कॉर्टिसोल. कॉर्टिसोल या तो एसीटीएच बोलेगा ज्यादा बना, उसे कहते हैं एसीटीएच डिपेंडेंट। दूसरा होता है एसीटीएच नॉर्मल है या लो है, कुशिंग खुद ही, ग्लैंड खुद ही बनाए जा रहा है। अब ग्लैंड खुद कब बनाएगा? जब ग्लैंड में प्रॉब्लम होगी। तो एड्रीनोकॉर्टिकल एडिनोमा, एड्रीनोकॉर्टिकल कार्सिनोमा, ये होते हैं रेयर। एडिनोमा है 5 to 10% और कार्सिनोमा है 1%। एसीटीएच जो बनाता है दैट इज 90%। उसमें से भी एसीटीएच कहां से आएगा? एसीटीएच कहां से आता है? नॉर्मली ब्रेन से आता है। सो ब्रेन प्रोडक्शन इज कॉल्ड एज कुशिंग डिजीज। एंड ब्रेन में क्या बनाता है? पिट्यूटरी एडिनोमा। सो पिट्यूटरी एडिनोमा इज द मोस्ट कॉमन कॉज इन एडल्ट्स, followed by ectopic ACTH production, which includes the oat cell cancers of the lungs. Right? So ectopic ACTH जो होता है, it is a part of carcinoids, paraneoplastic syndrome, small cell lung cancer, particularly oat cell cancer, few chromocytomas, and medullary thyroid carcinoma. So remember this table, right? तो थोड़ा सा एज देख के हम लोग वो हो जाते हैं। शुभम, मेडुहब के ऊपर आई एम टेकिंग अ रिवीजन PYQ सेशन। बाकी RR सीरीज मेरा ऑलरेडी दिसंबर से चल रहा है, वो मेरे अपने चैनल के ऊपर है। मैटर नहीं करता यार, मेडू हब पे हो या यहाँ पे हो, दोनों को सब्सक्राइब कर लो, नोटिफिकेशन आ जाएगा, मैं ही हूँगा। रिप्लेसमेंट नहीं है, मैं पहले बता रहा हूँ, बट क्लोज टू द एग्जाम की पॉइंट जैसे अभी कर रहे हैं वो हम सिस्टम वाइज थोड़ा सा रिवाइज कर लेंगे। सो आंसर टू दिस क्वेश्चन इज डी, पिट्यूटरी माइक्रोएडिनोमा। अब ये रिपीट होगा, गलत नहीं करना है। आई होप कुछ तो सीखा आज, चाहे कितना भी याद रहे। इसमें से ये तो याद रहेगा कि कुशिंग सिंड्रोम का सबसे कॉमन कॉज एडल्ट में क्या होता है? एसीटीएच का ज्यादा बनना। और एसीटीएच कहां से बनता है? नॉर्मल जगह से ज्यादा बनना, वहां पर ट्यूमर हो जाए, rather than ectopic ACTH प्रोडक्शन। आगे चलते हैं। 60-year-old man develops sudden onset breathlessness and chest pain. He has been bedridden for 10 days. What is the best investigation to perform? So what is your answer? So 60-year-old man, old age is there, sudden onset dyspnea and chest pain is there. He has been bedridden for 10 days. Bedridden for 10 days means immobilization. Immobilized patient, old age patient. ऐसे इसको दिमाग में, your mind should start processing the information. मेडिसिन का प्रॉब्लम पता क्या होती है? हम लोग ना ऐसे रैंडमली पढ़ते हैं, बोरिंग तरीके से पढ़ते हैं। ब्रेक डाउन की कहना क्या चाहता है? इमोबिलाइजेशन, ओल्ड एज पेशेंट हैविंग सडन ऑनसेट, एक्यूट ऑनसेट ऑफ डिज्निया एंड चेस्ट पेन। इमीडिएटली दिमाग में आ जाएगा क्या है डिजीज। यस, पेशेंट इज हैविंग PTE, pulmonary thromboembolism, also called as simply acute pulmonary embolism. So DVT हुआ, जिसकी वजह से हो गया उसको PTE। अब PTE के अंदर व्हाट इज द बेस्ट इन्वेस्टिगेशन टू डू? बेस्ट इज ऑलवेज एंजियोग्राफी। और कौन सा एंजियोग्राफी करते हैं? CT पल्मोनरी एंजियोग्राफी। डी डाइमर रेज होता है, बट डी डाइमर इज नॉट a specific investigation. D dimer can be elevated in DIC also. D dimer can be elevated in trauma also. D dimer can be elevated in renal compromise also sometimes. Snake bite, insect bite, rickettsial infection, they can also cause D dimer elevation. CT pulmonary angiography is considered the best investigation to perform. So pulmonary thromboembolism. So CT pulmonary angiography. अगर पूछे गोल्ड स्टैंडर्ड इन्वेस्टिगेशन क्या है, अगर CTPA not in the option, then your answer will be conventional angiography. If CTPA is not in the option. If CTPA is not in the option, right? And if someone says what is the most common ECG abnormality in pulmonary embolism, most common ECG abnormality, most common is sinus tachycardia, followed by S1 Q3 T3 pattern. S1 Q3 T3 याद कर लो, ये भी PYQs, right? आगे चलते हैं। Which of the following will help in making a definite diagnosis of bronchial asthma? अस्थमा पे आ गए। Which of the following will help in making a definitive diagnosis of bronchial asthma? एक एक करके चलते हैं। Look at the option. It is an actual PYQ. It is there in the past solutions books also. Accurate patient history. अरे हिस्ट्री से कैसे पता चलेगा दमा है पेशेंट को? अस्थमा is there. You cannot. That cannot be the answer. Focal wheezing is wrong. Asthma has bilateral wheezing. So ये तो वैसे ही नहीं होगा। HRCT chest. See, HRCT chest is done for a localized lesion. It is done for tumors. It is done for fibrosis in the lungs. Asthma is a bronchus ka constriction, episodic constriction and dilatation once the relief happens. So HRCT chest is not going to find anything. Spirometry, when you do, and you see after giving bronchodilator, FEV1 value improves more than 12% and definitely more sensitive if it is more than 15%. That is helpful in making the diagnosis. So basically, spirometric diagnosis is what you need to know in making a diagnosis of bronchial asthma. Yes, bronchiectasis also HRCT is done because those are structural problems. Bronchial asthma is not a structural problem, it is a functional problem. Bronchus constrict कर जाता है, normal होता है, constrict कर जाता है. That is what you see when you do spirometry. अगला क्वेश्चन भी इसी से रिलेटेड है, तो उसको भी देख लो, and then we will do a quick summary of GINA guideline, what you need to know if you have not read it already. So have a look here. I'm not talking the treatment here. ये अगला क्वेश्चन भी PYQ है, asked next year after this question came in FMG exam. Reversibility of airflow obstruction in asthma is defined as FEV1 change pre and post bronchodilator to be more than what value? What is your answer? Yes, Pratyusha, but they are described in pathology, but they are not useful in making the diagnosis. Charcot Leiden crystal, frankly speaking, कोई नहीं देखता है, वो लिखा होता है किताबों में. So, yes, my dear friends, absolutely right. More than 12%. तो अभी रिवाइज क्या करना है? So, अब हम करेंगे Global Initiative for Against Asthma, GINA 2024 Guidelines for Asthma Diagnosis. मैं अस्थमा इसलिए कह रहा हूं ताकि आपको याद हो जाए. But tomorrow when you will be conversing with someone, exact pronunciation is also important. Don't call it as asthma. That is how non-medical people say it is asthma. Asthma. अभी नहीं, अभी चल जाएगा. एमसीक्यू करने के बाद छोटी छोटी चीजें सीखना है ना. So GINA 2024 guidelines for asthma diagnosis or asthma diagnosis does not matter. So सबसे पहले there should be two components. Both should be present. मैं इसको simplified तरीके से लिख रहा हूं. Both should be present. First, there should be history of variable airway symptoms, also called as variable respiratory symptoms. Example, bilateral wheeze, shortness of breath, chest tightness, or cough. But this variable का मतलब क्या है? They should be episodic and show diurnal variation. Diurnal variation का मतलब more in the night hours or in the early morning hours compared to the daytime. Episodic का मतलब कभी कभी होगा but not always happening in the patient. Right? So history of variable airway symptoms plus there should be, second feature should be confirmed variable expiratory. I hope you know that asthma is a expiratory disorder, not inspiratory disorder, right? Inspiratory disorder में generally stridor होता है. Expiratory disorder में generally wheezing होता है. So confirmed variable expiratory airflow limitation on spirometry. So spirometry has to be done in all adult patients of asthma. So जब बात करते हैं confirmed variable expiratory airflow limitation, what are the key points I should know? Now it is a huge topic, but I will just write the key things that you need to know. First of all, there should be positive bronchodilator test. What is the meaning of positive bronchodilator test? हम FEV1 value करते हैं normally. Then we give a salbutamol inhalation. Then after that, we check for FEV1 again. If FEV1 improves by more than 12 to 15%, that is positive bronchodilator test. So what is positive bronchodilator test? Improvement in FEV1. Improvement in FEV1 or FVC by more than 12% or more than 200 ml. In bracket, you would write more sensitive if more than 15% or more than 400 ml. After giving bronchodilator, that is considered to be the first test. First spirometric test, which is sensitive. Second, average diurnal peak expiratory flow rate variability more than 10% in adults. हो सकता है बच्चों पे आ जाए, so more than 13% in children. तो हम मॉर्निंग इवनिंग करते हैं पीक एक्सपिरेटरी फ्लो रेट और देखते हैं वेरिएशन कितना है. If the variation is more than 10% in adult and more than 13% in children, that is another feature or diagnostic of asthma in the patient. Third, positive bronchial challenge test. Positive bronchial challenge test. What is positive bronchial challenge test? अगर you give methacholine, आप methacholine दो पेशेंट को and if it leads to decrease in FEV1 by 20% or more, that is considered to be a positive bronchial challenge test. Clinical setting में नहीं करते हैं till it is absolutely needed. Many patients can actually go into emergency. This is dangerous. So this is not very commonly done in the patient. Fourth thing, increase in lung function. Increase in lung function, bracket, increase in FEV1 by equal to or more than 12% or increase in peak expiratory flow rate by equal to or more than 20% on using 4 weeks of inhaled corticosteroid therapy. Inhaled corticosteroid 4 हफ्ते यूज करने के बाद, if the lung function improves by this value, then also it is diagnostic. And finally, improvement in FEV1 by FVC ratio, FEV1 or FVC by 12 to 15%. However, the latest 2024 guidelines say this is less sensitive test and should be done when the other tests are either equivocal or not possible. क्या एग्जामिनर सब पूछेगा? नहीं. But if you remember these values, you are having a tough paper, bad day, or somebody is asking you the value percentages of asthma, this is the latest one. And this is important. नहीं आएगा बहुत अच्छी बात है. But if it gets asked, it can be asked because 2024 January update has come in this year. So these are the latest values you are supposed to remember for your exam, right? इसको अलावा और टेक्स्ट की short notes की और foot notes की values हैं which I have edited out, which we actually do not use or which have a pitfall associated with them, right? So this is how you make the diagnosis. तो ये हमारे 2 MCQs हैं और उसके साथ में इसका एक मैंने short summary आपके साथ discuss किया. Please remember it, please add it to your notes. It is very, very important. Who knows, it might be a MCQ in the exam. So next question. 60-year-old male presented with progressive dysphagia to solids since past 1 month. Only to solids, not solids and liquids. He also has weight loss, loss of appetite. Similar question was asked in January paper of 2024 as well. और ये पुराना question है, उससे पूरे पहले का. Barium swallow was abnormal. बताया नहीं कि क्या abnormal है. Likely diagnosis in the patient. What is the likely diagnosis? You tell me. What is the likely diagnosis? What is the likely diagnosis? What is the likely diagnosis? A, B, C or D? मैं वेट कर रहा था गलती का. Carcinoma esophagus, my dear friends. एकलेशिया नहीं है दोस्त, ये एकलेशिया नहीं है। एकलेशिया 1 महीने से सिम्टम आए, वेट लॉस, लॉस ऑफ एपेटाइट हो गया, प्रोग्रेसिव डिस्फीजिया टू सॉलिड है, व्हाई वुड इट बी एकलेशिया कार्डिया? यू अंडरस्टैंड? दिस इज कार्सिनोमा इसोफेगस इन द पेशेंट। यस, देखो, उन्होंने कहा प्रोग्रेसिव डिस्फेजिया टू ओनली सॉलिड्स। क्या उन्होंने ये बोला कि सॉलिड्स एंड लिक्विड्स, लिक्विड्स पे मेंशन किया? नहीं किया। बट इन केस एग्जामिनर से साथ में वेट लॉस एंड लॉस ऑफ एपेटाइट आ गया, वेट लॉस हार्ट बर्न का हिस्ट्री होता, रेट्रोस्टर्नल पेन का होता, रिफ्लक्स का होता, then we would have gone, and longer duration symptom होते, more than 3 to 6 months, we would have gone in favor of achalasia cardia. But age देखो, achalasia cardia 60 ईयर पे स्टार्ट नहीं होता है, it tends to start at a earlier age. Weight loss and loss of appetite are considered points against reflux or achalasia cardia. And so the answer to the question is carcinoma esophagus. Watch out, उसने ये नहीं बोला कि लिक्विड्स को है या नहीं है, उसने सिर्फ एक चीज बोला, प्रोग्रेसिव डिस्फेजिया। प्रोग्रेसिव वर्ड इज इंपॉर्टेंट, and that is why the better answer to this question is carcinoma esophagus. थोड़ा डाउट हो रहा है, अगेन ये मैंने डिटेल वीडियो में डिस्कस किया है यूट्यूब के ऊपर, आप उसको सुन सकते हो। डाउट होगा, यू कैन आस्क मी अगेन, आई कैन शेयर द स्क्रीनशॉट विद यू after the class is over, obviously late at night, not immediately. So if MCQ says progressive dysphagia to solid, weight loss, this is the keyword, old age with weight loss and loss of appetite, and agar bole shouldering sign is present like this, irregular, can you see this irregular shouldering sign present, the likely diagnosis in the patient is going to be carcinoma esophagus. So patient is going to have carcinoma esophagus. Remember that achalasia cardia will have esophagia, it will have dysphagia, patient will achalasia cardia will have dysphagia to both solids as well as liquids. These patients also have retrosternal chest pain, they also have reflux, also called as regurgitation, और इनके अंदर हमें दिखता है bird beak appearance, also sometimes called as rat tail appearance. And these patients, achalasia cardia is considered to be a autoimmune condition. It is a autoimmune condition, and in these patients there is no progressive weight loss or loss of appetite, loss of appetite in the patient. Yes, right, आगे. Already I have reached the time limit which I had for my class, because 6 o'clock I am supposed to take some other session at some other place, and then I have a patient coming over at 7. So ऐसा करते हैं कि कुछ वन लाइनर्स और समरी फॉर्म में डिस्कस कर लेते हैं. अपार्ट फ्रॉम दैट, एज आई सेड, एंडोक्रिनोलॉजी एंड हिमेट प्लस वास्कुलाइटिस का एक सिनेरियो बेस्ड थिंग. ये क्वेश्चन होगा तो ये आंसर है, ये होगा तो ये आंसर है. These are the 2 recorded videos I will be putting up shortly. You can have a look at them there also, right? तो topics not to be missed during revision, बहुत सारे लोग पूछते हैं, so याद कर लो. मेडिसिन की बात कर रहे हैं, so dysphagia related disorders, inflammatory bowel disease, JVP, abnormalities, hyperkalemia and hypokalemia और उनका मैनेजमेंट, स्ट्रोक डिटेल में करना है, एक्यूट कोरोनरी सिंड्रोम डिटेल में करना है, न्यूरोलॉजिकल डिसऑर्डर्स which includes Alzheimer disease, Parkinson disease, Prion disease, Guillain-Barré syndrome, multiple sclerosis, myasthenia gravis, Lewy body with dementia and frontotemporal dementia. ऐसा कोई पेपर है ही नहीं जिसमें something out of this is not asked in the exam, right? Then you have vasculitis. Vasculitis के अंदर भी focus on HSP, Kawasaki disease, Wegener's granulomatosis, Takayasu, temporal. Then you have the evergreen topic, SLE, Sjogren, scleroderma, and rheumatoid arthritis. Then you have the pulmonology, where you have pulmonary embolism. You also have topics like और वो जो ग्राफ होते हैं, so pressure volume curves, and then you have the glomerular disorders. उसमें nephrotic versus nephritic, the approach we have already done. ये topics not to be missed है. इसका मतलब ये नहीं है कि इसमें से आएगा, but this is something that you have to do, that you have to be thorough with this. And जय, आप देखो PDF आप लोग बोलोगे तो मैं शेयर कर दूंगा, मुझे कोई प्रॉब्लम नहीं. I will share it, but where to share, that is also something I have to figure out. So I'll figure out. I'll share with the Meduhub team so they can share it with you, है ना, उनके साथ मैं शेयर कर दूंगा. And मुझसे somebody had asked me कि सर एक बार सिंपल लैंग्वेज में हमने टेबल तो पढ़ लिया है हेपेटाइटिस बी का, लेकिन फिर भी याद नहीं होता है, गलतियां करते हैं उसमें. तो याद कर लो कि इन हेपेटाइटिस बी वायरस रिलेटेड एमसीक्यूज, अगर आपके पास ये एमसीक्यू आता है तो समरी क्या करनी है याद कर लो. सिंपल लैंग्वेज में बता रहा हूं, टेबल नहीं, सिंपल लैंग्वेज में. टेबल तो करना है आइडियली. सो अगर एमसीक्यू बोले इफ HBsAg is positive, surface antigen positive, antibody नहीं, तो infection is present. So infection is present. Okay. अब दो possibilities होंगी. If question says IgM anti-HBc है, तो it is going to be acute hepatitis B virus infection. If question says IgG anti-HBc है, तो it is going to be chronic hepatitis B virus infection. Okay. अगर MCQ बोले HBsAg is negative, so there is non-infected patient. Non-infected patient. Okay. अब इस non-infected patient के अंदर how would you simplify? If HBsAg negative है, only anti-HBs is positive, rest all negative or not mentioned, then patient is likely to have vaccination. So vaccinated against hepatitis B virus is the status. If MCQ says anti-HBs is positive, antibody बना, और IgG anti-HBC भी है, तो इसका मतलब HBsAg तो चला गया, लेकिन एंटीबॉडी बना उसके अगेंस्ट और IgG भी आ गया. तो वैक्सीनेशन से तो IgG नहीं आएगा, HBC वाला नहीं आएगा, राइट? इन्फेक्शन से आएगा. तो इन्फेक्शन से रिकवर हो गया, सो योर आंसर विल बी प्रीवियसली इन्फेक्टेड बट नाउ रिकवर्ड. Previously infected but now recovered. And third, if only IgG anti-HBC is positive and rest all negative, in such patient, it is either going to be a low-level carrier or it is going to be remote infection. Remote infection. और याद कर लो कि every single, ये लगाकर देखना, if you in case you feel कि the table has become repetitive और मुझे याद नहीं हो रहा और I am losing my accuracy, apply these scenarios and your answer will be right. You can apply this to any MCQ of FMG when you are practicing PYQs. It has at least 5 to 6 PYQs hidden in this table itself. बाकी देखो वन लाइनर तो पढ़ोगे ही ना, मैं अज्यूम कर रहा हूँ. तो एक शॉर्ट रिवीजन सेशन था, एंड माय फोकस वाज, माय टारगेट वाज फॉर यू पीपल टू कवर द मैक्सिमम दैट यू कैन. जस्ट अ मिनट, गिव मी जस्ट 30 सेकंड प्लीज. राइट. सो ये हमारा आज का डिस्कशन खत्म हो गया. इन टुडेस डिस्कशन आई हैव टेकन एज अ टेम्पलेट अबाउट 15 to 20 questions, and in each question we have discussed about 5 to 6 questions in addition. So about I think 100 plus MCQs with case scenarios with latest updates we have covered here. I hope some of you will be benefiting out of it. add it to your notes. At the same time, this is not a replacement for the existing preparation. And this PDF which I have shared, I will share with you. Before you leave, Med Eduhub के ऊपर there are other similar sessions which are going to be held. So please subscribe to the channel. पुनीत लास्ट वीक डेली इवनिंग में क्लास कर लो यार. मेरे ना बाकी चीजें भी होती हैं बिकॉज आई एम एसोसिएटेड फॉर नीट पीजी आल्सो, एसएस आल्सो, तो मुश्किल हो जाता है. बट ओके, आरआर एंडो, आरआर miscellaneous, which includes hemat as well as vasculitis and some infections. I will be posting in the next 2 to 3 days. That will be posted on my channel, right? Apart from that, I will try कि एक और PYQ का similar session में ले. Don't worry, exam से पिछले दिन नहीं लूंगा. I will try to schedule it. So let me discuss with the team also, and I will try to take a similar 1.5 hour session, different topics, different MCQs from what we discussed, and I hope you will benefit from it. तो बाकी का तो आगे का क्लास और बाकी सारा क्लास जो है, I will have to figure it out. लेकिन आज हमने जो है टाइम मिल गया हमें. I have stretched myself. We have covered what I had planned for all of you. See, one-liners अकेले करने से बात नहीं बनती है. इस तरीके से करने से you have a better retention. This is what I feel, and I have tried to cover the maximum things without going overboard. So I hope you all benefit from it, है ना. Stay in touch, stay positive, अच्छा रहना है और तैयारी करना है. We connect again. In case of any doubts, as I said, you can always message me on Instagram, and please subscribe to my channel also, and please subscribe to Med Eduhub channel also. So some of the excellent faculties will be taking your revision classes also. Okay, Puneet. Okay, Puneet. Even if for 40 minutes, 45 minutes, इससे भी fast rapid fire, मैं एक बार जरूर आऊँ. ठीक है? Let me just talk, and then you will get to me. Thank you so much. All the very best. Bye bye, guys. Do well.